Obstetric ESI PGMSR Vasai Darapur under ages of AOGD and Delhi Southwest. All people 10 to 90 years of age. Adolescence is a phase of life of rapid growth and physical, audible, and behavioral changes. They contribute more than 1.2 billion worldwide and about 21% of Indian population. Morbidity and mortality in this age group is mostly due to preventable causes. Existing adolescent health programs, they focus on rendering services like immunization, health education for sexual and reproductive life, nutritional education and supplementation, anemia control measures, and counseling. Universal coverage of adolescent-friendly clinics is highly recommended. To be cost-effective, all health services addressing adolescent issues, they should come under one single coverage. With this, I once again welcome all of you. It's my pleasure to welcome Dr. Anita Rajoria, Chairperson of Adolescent Health Committee, AOGD.
Funny all this time.
Worker in the field of adolescent health, in addressing multidisciplinary health problems of women. She is also a strong contender for the chairperson of. I request Dr. Anita Rajoria.
Thank you, Dr. Taru. She is a very active member of my Adolescent Health Committee, AOG. Thank you for organizing this webinar for us under aegis of Adolescent Health Committee. I'm really, overwhelmed by the presence of all participants. I welcome you all. I welcome Chief Guest Asmita Ma'am, our AOGD President, Dr. Sharda Jain, our guest of honor. She's the Secretary General of DGF. Thank you, ma'am, for giving us this platform to share it with DGF. I'm very honored to have presence of our respected Dean ESI PGF MSR Vasai Darapur, Dr. Pascal D'Souza, sir. Thank you for gracing the occasion. MS ma'am, Dr. Deepika Govil, patron Dr. Sangeeta Gupta ma'am, who has been senior consultant OBG there. Organizing secretaries, Dr. Sanjana Vadva, and Joint Secretary, Dr. Divya Solanki. Thank you for organizing this very important webinar. And I'm really thankful to President DGF Southwest, Dr. Shashilata Kabra, also for being a partner with Adolescent Health Committee and ESI Vasai Darapur in organizing this prestigious webinar. I'm also welcoming with due respect all my chairpersons, speakers, moderators, and panelists who will be giving and exchanging their academic ideas and giving very good carry home practical messages to all the delegates who are attending this Prevent, Promote, and Protect Adolescent Health. And I'm really thankful to ICOG also. If we are able to get ICOG credit points for that, I'm really thankful to Dr. Uday Thanawala, Parag Piniwale, and Ashok Kumar sir for the same. So thank you everyone. Thanks for joining and happy learning, dear all. Over to you, Dr. Taru. Thank you so much for making us a partner.
Thank you, Dr. It's my honor to welcome the chief guest of the day, President AOGD, Dr. Asmita Rathore, Madam. She is named a strong pillar of AOGD in different perspectives with special interest in fetal medicine. I request Madam to say a few words. Dr. Asmita, Madam.
Hello. Am I audible?
Yes, ma'am.
Hello.
Yes,
hello. Very good afternoon. Can you hear me, Dr. Taru?
Yes, ma'am. Yes, ma'am. You are audible.
Hello. Yeah. A very good afternoon. It's really a great pleasure to be part of the CME on Prevent, Promote, and Protect Adolescent Health. Catching them young and educating and empowering the adolescents about the knowledge and services accessible to them is probably the greatest investment for women's health. I congratulate Dr. Taru, HOD Gynae at ESIS and PGIMSR, and Dr. Anita for the chairperson of AOGD subcommittee on adolescent health.
Thank you, ma'am. Thank you, ma'am. Respected Dr. Shada.
Need to have a very special approach how to approach the girls and how to empower them. The scientific program designed for this CME is really a very good, very comprehensive, and the experts are going to deal with him. I'm sure this all will benefit all of us and all the healthcare provider, and we can deliver better services to our adolescents. Thank you so much, Dr. Taru, for this CME.
Thank you, ma'am. Thank you for the kind words.
Thank you.
Arjun, Madam, General Secretary DGF, has sent her regrets to be virtually available with us. However, her blessings are always with us. I pay my regards to Madam. Now I invite Dr. Shashilata Kabra, President Delhi Gynae Forum Southwest. She's a very dynamic and a vibrant person. She is famous as PPH lady, and she has trained many doctors of Delhi and NCR by conducting PPH drills. Dr. Shashi, please.
Thank you, Dr. Taru, for such a kind introduction. So, very good afternoon, Dr. Ashmita Rathore, ma'am, President AOGD, Dr. Pascal D'Souza, Dean ESI PGI MSR Vasai Darapur, Dr. Deepika Govil, Medical Superintendent ESI Vasai Darapur, Dr. Taru, my dear friend, Professor and Head of the Department of ESI Gynae Department PGI MSR. Thank you so much for organizing the webinar in association with the Delhi Gynae Forum Southwest. The topic is very pertinent in present circumstances. We are almost having an epidemic of PCOD. Lack of exercise and pizza, pasta, burger culture in our girls has led to a sharp rise in the incidence of PCOD, and consequently, many health issues like anovulation, infertility, and endocrine and metabolic problems. And we are also facing lots of problems related to unprotected sexual practices among adolescents. And it is high time we need to discuss contraception, reproductive tract infections, sexually transmitted infections, their prevention and treatment also. Today, we have stalwarts for today's webinar to discuss all these adolescent problems. Dr. Sangeeta Gupta ma'am, Dr. Sanjana, Dr. Divya, Dr. Nipur, Dr. Chandan, Dr. Leena, Dr. Yashika, Dr. Rachna, Dr. Niharika, and Dr. Setna. I wish all the best for today's webinar and hope to have a great academic feast. Thank you.
Thank you, Dr. Shashi. Thank you so much. I welcome Dean ESI PGMSR Vasai Darapur, Dr. Pascal D'Souza. He's a thorough gentleman, wonderful administrator, a very good clinician, and a keen academician. That is always encouraging and motivating us for organizing academic activities. Shivam, sir, with us?
No, ma'am.
Okay. I also welcome the Medical Superintendent ESI Vasai Darapur, Dr. Deepika Govil, Madam. Madam is always helping and encouraging us in conducting academic activities, awareness programs. She strongly believes in adhering to protocols and guidelines in respect to patient care. This webinar has been possible. I request Dr. Deepika Govil, Madam, to say a few words. Madam, are you with us?
Yes, she's there.
Dr. Deepika, ma'am.
Good afternoon. Good afternoon and warm welcome to all our guests and speakers. And I congratulate you, Dr. Taru Gupta, HOD Obstetrics Gynaecology Department of ESI Hospital, PGI MSR Vasai Darapur, for conducting this program, and which is really the need of the hour in the present scenario. And my best wishes to everyone. Thank you.
Ma'am. Thank you for your encouragement and motivation. Thank you so much, ma'am. Now I request Dr. Sanjana Vadhwa to carry forward and start the scientific proceedings.
Hello, good afternoon and welcome all. I would like to welcome our chairpersons for the first session, Dr. Sangeeta ma'am. Dr. Sangeeta ma'am is our consultant and ex-HOD of our ESI Obs and Gynae. She is always been a strength and a pillar, a person who's always actively involved in our academics. Without her support, we won't have been able to conduct this. Thank you, ma'am, for joining us today. The next esteemed chairperson for the session is Dr. Deepthi Goswami, ma'am. And it's my honor to welcome her on this webinar. She's Director, Professor, and Unit Head in charge Gynae Endocrinology Clinic, Maulana Azad and LNJP Hospital. Welcome, ma'am. We are happy to have you on the board, ma'am. Our next chairperson, esteemed ma'am, for this session is Dr. Shashi ma'am. And ma'am is very active. We have seen her and she has always been an inspiration. She's actively involved in all the teaching activities. Welcome you, ma'am. Thank you for being part of this, ma'am. Sangeeta ma'am, please welcome our first speaker for the eve session, ma'am.
Thanks, Dr. Asmita and Dr. Anita.
Please unmute yourself. Unmute.
An opportunity to organize this webinar. I call upon our first speaker, Dr. Nupur Gupta. Dr. Nupur is the senior specialist at our hospital, that is at ESI hospital. She is a very hardworking, she's got in-depth knowledge of the subject. But you can ask anything from her at any time. So she has got a very in-depth knowledge, and she has got particular interest in high-risk pregnancy, in infertility, and as well as endoscopy surgery. Dr. Nupur, I will invite you to say a bird's overview about the adolescent health. Welcome, Dr. Nupur.
Thank you, ma'am. Am I audible?
Yes, ma'am.
Good afternoon, everyone. Hello, am I audible?
Yes, ma'am.
Good afternoon, everyone. At the outset, I would like to thank Dr. Taru, Dr. Sanjana, and Dr. Divya for inviting me and giving me the opportunity to speak on this topic. I will be speaking on adolescent and its related health problem. Now, the term word adolescence, it is derived from a Latin word adolescere, which means to grow or to mature. Nearly 1/6 of the world population is constituted by adolescent, and in India, about 25% of the population is constituted by adolescent. There are about 253 million adolescents in the age group of 10 to 19 years in India, as per National Health Mission 5. The adolescent age group, it comprises from 10 to 19 years of age. It is further divided into early adolescent, which constitutes 10 to 13 years, middle adolescent, which constitutes 14 to 16 years, and late adolescent, which constitutes about 17 to 19 years. The adolescent, it is a very critical transitional period, which includes biological changes of puberty and developmental tasks, such as normative exploration, and at the same time, the individual is learning to be independent. It is a time of physical and emotional change as the body matures and the mind becomes more questioning. Adolescent age, these are the formative years of a life of an individual when major physical, psychological, and behavioral changes takes place. At the same time, it is the period of preparation for undertaking greater responsibilities, including healthy, responsible parenthood. As we all know, nowadays, the age of onset of puberty is decreasing, yet the age at which mature social roles are achieved is increasing. So the adolescent is lasting longer, and the all needs, energy and iron requirements which is needed for this period is increased. Why adolescent health needs? Overall health, mortality, morbidity, and population growth scenario, investment in adolescent reproductive and sexual health will yield dividend in terms of delaying age at marriage, reducing incidence of teenage pregnancy, meeting unmet contraceptive need, reducing the maternal mortality, reducing STI, and reducing HIV prevalence. It will also help India realize its demographic dividend, as healthy adolescents are an important resource for the economy. Now, according to WHO 2021, about 1.5 million young adults aged between 10 to 24 years died in 2019. And the major cause of death was violence, road traffic accidents, maternal conditions, which were among the leading causes of death. Half of all mental disorders in the adulthood start by the age of 14, but most cases are undetected and untreated. Substance abuse in adolescence is associated with higher risk of developing dependence and other problems during adult life. Globally, there are about 43 births per 1,000 girls in the age group of 15 to 19 years per year. Now, what are the health problems which are faced by an adolescent age group? Important ones are unsafe sex, which can lead to sexually transmitted infections, HIV, AIDS, early and unintended pregnancies, nutritional disorders, which can range both from malnutrition, anemia, and to overweight, substance abuse such as alcohol, tobacco, mental health concerns, which is a major problem as it leads to academic problem, dropping out of school, increased incidence of homicides and suicide, and other injuries and violence. Now, coming to nutrition and micronutrient deficiencies, as per National Family Health Survey 5, anemia has emerged as a major health concern among adolescents, especially among girls. And the incidence has increased from 2015 to 2021. In boys, it has increased from 29 to 31%, while in girls from 54 to 59%. So to manage this, Government of India has recommended weekly iron and folic acid supplement to both in-school boys and girls and out-of-school girls, plus annually deworming of the adolescent age group. Now, on one spectrum is undernutrition, and on the other spectrum is the obesity, which is nowadays increasing very much. Globally, in 2016, over 1 in 16 adolescents were overweight. 23.9 million were overweight, out of which 30% were girls, and 12.7 million were obese, out of which 15% were girls. And the incidence was more in developed countries. Being overweight or obesity, it leads to health problem later in life also. Especially in girls, they are at risk of abnormal period and polycystic ovarian syndrome, a condition which we all know causes excessive hair growth, acne, male type of baldness, which further causes body shaming to these adolescent age group girls, and they further lead into depression and other mental problems. Besides this, it can lead to infertility and metabolic syndrome later in life. But fortunately, obesity and its consequences are usually preventable and reversible. We all know obesity is due to sedentary lifestyle and faulty eating habits of the adolescent age group, which are more prone for junk foods. And so to prevent it, developing healthy eating habit is very essential. Reducing the intake of fat, which are high in saturated fat, should be reduced. And WHO recommends moderate to vigorous exercises of 60 minutes during week. Now, coming to early pregnancy and childbirth globally, leading cause of death for girls between age of adolescent age group are complications from pregnancy and childbirth. Approximately 12 million girls aged between 15 to 19 years and about 8 lakhs girls under 15 years give birth each year in the developing region. So adolescents need and have a right to comprehensive sexuality education, curriculum-based process of teaching and learning about the cognitive, emotional, physical, and social aspect of sexuality. They have a right of information about contraception, and if the girl becomes pregnant, then they should have an access to safe abortion. One of the goal under Sustainable Developmental Goal by 2030 is universal access to sexual and reproductive healthcare services, including for family planning, information and education, and integration of reproductive health into national programs. Now coming to infectious disease, though the incidence has decreased because of improved childhood vaccination, yet diarrhea and lower respiratory tract infections are among the top 10 causes of death among this age group. Infections like human papilloma virus that normally occurs after onset of sexual activity can lead to both short-term disease in form of genital warts, but more importantly is that it can lead to cervical and other cancers later in the life. So in an early adolescent age group, that is between 9 to 14 years, it is the optimal time for vaccination against HPV infection, and it is estimated that if 90% of the girls globally get HPV vaccine, more than 40 million lives could be saved over next century. But the sad part is that in 2019, only 15% of girls globally received the vaccine. Another infections, HIV, it is estimated about 1.7 million adolescents are living with HIV in 2019. Though the new infections among adolescents has decreased, but they still account for about 10% of new adult HIV infection, with 3/4 among adolescent girls. And more to worse is that the adolescent living with HIV have a worse access to antiretroviral therapy, and this is because of limited provision of adolescent-friendly services. So to prevent this, we should educate adolescents about the HIV, and they should be taught how to protect them, and they should have a means to protect them. Now coming to substance abuse, drinking alcohol is very common among the adolescent age group. Alcohol, it reduces self-control, increases risky behavior, leading to unsafe sex, dangerous driving, injuries, violence, and premature death. Besides this, in adolescent, it is associated with neurocognitive alterations, which can lead to behavior, emotional, social, and academic problem later in their life. About half of the high school girls, they drink, and more than 25% of them smoke and do binge drinking. What causes increased substance abuse in this age group is the peer pressure, stress, feeling invincible. The adolescent age group, they consider themselves as God. They say they are better than everybody. So these all things, they provoke them to these substance abuse. So to prevent it, population-based strategies and education, right, starting from the family level, school level, community, and the national level is to be done. One of the major concern is the health problem among adolescent age group. Depression, it is the leading cause of illness, and suicide, it is the third leading cause of death in adolescent age group. Mental health conditions account for 16% of global burden of the disease and injury in adolescent age group. Half of all mental disorders in adulthood start by age of 14, but most cases are undetected and untreated. The consequences of not addressing adolescent mental health extends into adulthood, impairing both physical and mental health and limiting opportunities to lead fulfilling lives as an adult. What lead to increased incidence of mental health problem is the violence, poverty, stigma, exclusion, and living in humanitarian and fragile setting, which lead to increased risk of developing mental health problems. Now coming to violence, interpersonal violence is the fourth leading cause of death in adolescent age group. About 40% of adolescent boys and 37% of adolescent girls are exposed to bullying. Sexual violence is also there. And nowadays, because of increased use of internet, cyberbullying is also there. Now coming to unintentional injuries, which are the leading cause of death and disability among adolescents. The injuries are mostly due to motor vehicle accidents, drowning, poisoning, burns, falls, sports, misuse of firearms, suffocation, animal bites, and in today's era, texting and driving, it has a new dangerous combination, especially among the teen drivers. So to prevent them, we should educate them. We should tell them about the road safety rules, and proper counseling has to be done. So to prevent this, Government of India has initiated various health programs, which all aims, we can remember by a mnemonic of adolescent itself, which aims at adoption of healthy lifestyle, develop appropriate strategies, organize adolescent and youth friendly clinic, life skill training programs, educate them, provide them safe, secure, and supportive environment. Proper counseling of the adolescent age group should be done. Enable and empower for responsible citizenship, networking for experience sharing, and training for income generation and teen club. Just to name some of the programs, reproductive maternal newborn child and adolescent health program was launched in 2013. Rashtriya Kishore Swasthya कार्यक्रम was launched in 2014 by Ministry of Family and Healthcare, which besides health and nutrition also addresses upon substance abuse, nutrition, injuries, violence, non-communicable disease, and mental health condition of adolescent age group. Adolescent reproductive and sexual health, adolescent friendly health clinic, these are very important. They aim at counseling and curative services at primary, secondary, and tertiary level of care, and they act as a first level of contact. Then there is a menstrual hygiene scheme which is launched by Ministry of Family and Health, Family Welfare Program, Family and Health Welfare, to increase awareness among adolescent girl about the menstrual hygiene. So to conclude, I would say the issues of independence, in identity, sexuality, and relationships, they define this critical developmental stage. Adolescents are susceptible to severe preventable and treatable health problems. The behavior patterns established during these developmental periods help determine young people's current health status and their risk for developing chronic disease during adulthood. Proper counseling and education of the adolescent age group is very necessary, and we should not forget today's adolescents are tomorrow's parents, teachers, and community leaders. Thank you for your patient hearing.
Dr. Sangeeta madam or Dr. Deepti?
Yes, I will congratulate the speaker for a very nice talk introducing us to the health of adolescents and the issues that are of importance when dealing with the adolescent health and adolescents in general. So now, may I call the next speaker, please? Am I audible?
Yes, ma'am.
Have we lost the connection or something? Yeah, so the next speaker is a dynamic faculty from All India Institute of Medical Sciences, Dr. Alpesh Goyal, and he will be delivering a talk on precocious puberty. So precocious puberty is an issue which is now coming with increasing number of patients to the clinicians, and they may present to the gynecologist, to the pediatrician, and of course to the endocrinologist. And it is one topic with most of us would agree are not very comfortable as gynecologists in dealing with these issues. So I'm sure Dr. Alpesh is going to give a fantastic talk and remind us what all we need to do when the patient of precocious puberty presents for evaluation. Dr. Alpesh.
Thank you, ma'am. I hope my slides are visible.
Yes, these are visible.
Okay, thank you so much, ma'am. Good afternoon, everyone. Thank you for this invitation. I'll be talking on precocious puberty, especially focusing on precocious puberty in girls. So what exactly is sexual precocity? Onset of secondary sexual characteristics before the age of 8 years in girls and 9 years in boys has traditionally been defined as sexual precocity. Although the age of onset of puberty in girls can be debated, it has been debated that it can be normal age of puberty can be between 6 to 8 years, but traditionally 8 years is considered as the age at which you should consider careful evaluation if puberty sets in before this age. In Indian girls, the age of philarchy is roughly around 10.8 years and age of menarche is at 12.5 years. So how do we approach a patient with sexual precocity or precocious puberty? So our first and most important sorry. So first and the most important issue when we are dealing with a patient with sexual precocity is to determine whether the patient has sexual precocity or not. And this is determined using a careful clinical evaluation and tenor examination. If sexual precocity is present, it could either be a variant of normal puberty, which is obviously monocomponent based and is not progressive. That is, there is no progression of secondary sexual characteristics or very slow progression. So this could be premature philarchy, premature adrenarche, or premature menarche. On the other hand, precocious puberty is characterized by a progressive course where there is progression of secondary sexual characteristics along with growth, acceleration, and skeletal maturation. This in turn could be a central or GnRH dependent form or a peripheral or GnRH independent form, and this I will deal in my subsequent slides. Once we have determined whether the cause is central or peripheral, you have to determine what is the exact cause, whether it is organic or it is idiopathic, and then plan the treatment accordingly. So moving on to variants of puberty, which are actually much more common as compared to the precocious puberty, similar to variants of short stature or variants of tall stature that we see, which are more common than organic causes of short or tall stature. So you can have premature philarchy where there is monocomponent development, that is, there is isolated breast development without any changes in terms of pubic hair development or growth of uterus. This is generally non-progressive or very, very slowly progressive, most commonly seen at age of less than 3 years. There is no skeletal maturation, uterus is prepubertal, and you get prepubertal or early pubertal estradiol levels. However, it is important to follow these kids because 10% of them can actually progress to central precocious puberty. Moving on to premature adrenarche, which is a condition where adrenal androgens increase prematurely, most commonly seen between age of 6 to 8 years, more common in girls, more common in girls with history of CNS injury. It is again non-progressive. It may be associated with mild increase in skeletal maturation. However, there is prepubertal uterus and gonadotropin levels are again prepubertal. It is important that this condition is not totally benign. It is considered as a harbinger of future metabolic problems, including PCOS, adult cardiovascular disease, and dyslipidemia. Premature isolated menarche is something which is considered as a counterpart of premature philarchy. There is predominant FSH secretion. Now, it is not known whether there is increased sensitivity of estrogen to uterus, uterine estrogen sensitivity, or there is transient activation of hypothalamic pituitary gonadal axis with predominant FSH secretion. But it is characterized by isolated vaginal bleed and it is self-limiting. However, it is important that a local cause, including sexual abuse, infection, foreign body, and trauma, are ruled out before we consider this condition. Now, having discussed the causes of normal variants of puberty, we move to precocious puberty, which is characterized by a progressive development of secondary sexual characteristics. More than one components are involved, and there is usually skeletal maturation and advanced growth. So precocious puberty could be central, that is, where there is premature activation of hypothalamic pituitary gonadal axis, which means that it is GnRH dependent, or it could be peripheral, that means there is autonomous production of estrogens or testosterone by gonads, or there is production of androgens by adrenals, or there is an exogenous exposure to the patient. So if we see the causes for central precocious puberty, this could be idiopathic, and an idiopathic form is more common in girls as compared to boys, where an organic form is more commonly found. The non-idiopathic causes include hypothalamic hamartoma, which is in fact the most common neurogenic cause of central precocious puberty. Other causes include hypothalamic astrocytomas, optic gliomas. History of CNS radiation is important. History of childhood infections, CNS infections, and there are some genetic diseases which can also cause central precocious puberty. Importantly, after treatment of a peripheral cause of precocious puberty, you can get central precocious puberty. Peripheral precocious puberty, most important cause is exogenous exposure to estrogens, the estradiol preparations, topical estradiol preparations used by parents or other members, hypothyroidism, ovarian cysts or ovarian tumors, which can produce estrogen, McCune-Albright syndrome, and a case of which I will discuss, congenital adrenal hyperplasia, which can cause peripheral precocity in both boys and girls, and HCG secreting tumors and testotoxicosis, which cause peripheral precocious puberty, but the precocious manifestations are only limited to boys. Now, how do we differentiate between central and peripheral precocious puberty? Now, both forms of puberty are progressive. Both forms of puberty are associated with growth acceleration, skeletal advancement. But as we discussed, central precocious puberty is always isosexual. That is, the pubertal development is in line with the sex of the individual. However, peripheral precocious puberty could also be heterosexual. That is, the development of puberty could be in reverse to the sex of the individual. That is, there could be virilization in a female or feminization in a male, as in case of congenital adrenal hyperplasia and adrenal tumors. Central precocious puberty is ordered. That means that it follows the tempo of normal puberty. There will be philarchy followed by pubarchy and then menarche. However, peripheral precocious puberty can be totally chaotic and disordered, and there could be rapid breast development followed by appearance of vaginal bleed within few weeks to months, and it is characterized usually by a rapid tempo of progression. LH levels are usually pubertal in central precocious puberty as compared to prepubertal LH levels in peripheral precocious puberty. Estradiol levels are elevated in central precocious puberty, but they are pubertal stage appropriate. So if a patient is in early stage puberty, say stage 2 or 3, estradiol levels will be lower, but pubertal stage appropriate. However, in peripheral precocious puberty, you usually get marked elevation of estradiol levels. These levels are more than 75. We have seen levels up to 1000 picograms per ml in peripheral precocious puberty. As I had said, there will be advancement of growth and skeletal maturation in both forms of precocious puberty. However, there are important exceptions. If there is a history of CNS radiation and associated growth hormone deficiency, you may not get characteristic growth acceleration that you get in precocious puberty. Similarly, if there is hypothyroidism, which is a very important cause of peripheral precocious puberty, you may get actually bone age delay and poor height velocity. Similarly, an adrenal tumor, which is also steroid producing, you can get poor height velocity. In central precocious puberty, you generally don't get cycles of breast growth and regression, while in peripheral precocious puberty, you can get these cycles because there will be development and growth of ovarian cyst, which regresses, and then there is a estrogen withdrawal related vaginal bleed. How do we approach in terms of history and physical examination? We look at components, whether there is isolated breast development, isolated adrenarche, or there is multiple components are involved. Whether this is progressive or non-progressive, this is seen typically over a period of 6 to 12 months. What is the tempo of progression, the importance of which I have discussed? What is the growth like? It is important to plot serial growth or serial height of the individual, and also the height of the individual in respect to the parental height. Exogenous exposure is very important, and other history pertinent to central and peripheral causes. For example, history of an intracranial lesion, or history of exogenous exposure, history of hypothyroidism. Family history is important, obviously, for some causes of central precocious puberty which are genetic, or also for causes such as congenital adrenal hyperplasia. It's important that on examination, we look at height, mid-parental height, height SDS, plot using appropriate growth charts. Tenor staging is very, very important. Look at vaginal mucosa and look whether there is features of estrogen exposure. And we also look at features of heterosexual puberty. In cases of CAH and adrenal tumors, you can get clycomegaly, virilization. Look for abdominopelvic masses, which can be present in patients with large ovarian cysts or ovarian tumors. And other examination could be directed to pertinent respective causes. How do we investigate? So The diagnosis of precocious puberty is essentially clinical. It is based on good clinical history taking and physical examination. Investigations are required to support the diagnosis and to differentiate progressive from non-progressive forms, and amongst progressive forms to differentiate central and peripheral causes. So you could have bone age, which is not accelerated in patients with variants as compared to precocious puberty, where there is an acceleration of bone age, which is typically advanced more than 2 years compared to the chronological age. Gonadotropins, which will be pre-pubertal in peripheral precocious puberty or variants of puberty as compared to pubertal gonadotropins or LH levels in central precocious puberty. Sex steroids, estradiol levels will be elevated in patients with precocious puberty. DHEAS and 17-OHP are needed if you are suspecting premature adrenarche or you are suspecting CAH or cause like adrenal tumors. T4 and TSH if you are suspecting a peripheral precocious puberty due to hypothyroidism, which is famously known as von Wig-Grumbach syndrome, which can present with galactorrhea, breast development, and recurrent cycles of vaginal bleed. HCG is needed in boys only in special cases. Bone scan will be needed if you're suspecting McCune-Albright syndrome. And ultrasound of pelvis for looking at uterine length, uterine volume, and endometrial thickness is very important to differentiate between premature thelarche and central precocious puberty, because as we discussed, thelarche is a problem which is limited to breast. So you will get a prepubertal uterus, which is typically less than 3.4 centimeters, volume is less than 1.8 ml, and endometrial thickness is less than 2 ml. So it's important to ask for a properly performed ultrasound pelvis when you want to differentiate between these two close differentials. Now, what is the role for agonist stimulation test in diagnosis of precocious puberty, central versus peripheral? So if you have a basal LH of more than 0.2 to 0.3 international units per liter using modern third generation immunoassays, that's got a very high specificity for central precocious puberty, but there is low sensitivity. So if you have a low basal LH, you still may have central precocious puberty and may require GnRH agonist stimulation test. However, if you are getting a high LH levels in setting of precocious puberty, you may not need to perform a GnRH agonist stimulation test. Now, how is this test performed? So this test is performed using a leuprolide or triptolin, which are common GnRH agonists which are available. GnRH, natural GnRH is no longer available. Earlier, it was used in an IV formulation. You pick LH at baseline and at 1, 2, and 4 hours, and peak LH of more than 5 to 6 international units per liter on a CLIA-based immunoassay is suggestive of central precocious puberty. So we had published a review on the various dynamic tests, and the details of these tests are available in this review. You also image the patient for evaluation of cause. So if it is a central precocious puberty, you want to look at a organic cause, especially in boys, and in girls, especially less than 6 years of age. Between 6 to 8 years of age, area is again gray. You may or may not image, but if there are any neurogenic features, you should definitely do a brain imaging in girls, even between 6 to 8 years of age, to look for hypothalamic hematoma or any intracranial space occupying lesions. Ultrasound abdomen and pelvis and CT abdomen and pelvis will be required to look for ovarian or adrenal causes in peripheral causes of precocious puberty. So as we can see, this is a patient who has presented with central precocious puberty, and you can see an iso-intense lesion in the hypothalamic region, in the suprasellar region, and this is typical of a hypothalamic hematoma. On post contrast, it does not enhance, and it is T1 and T2 iso-intense. This is another patient who had presented. This was a boy actually who had presented with peripheral precocious puberty and had severe virilization and was found to have large adrenal mass, turned out to be an adrenocortical carcinoma. And interestingly, once we removed the adrenocortical lesion, the child went into remission, but then entered into central precocious puberty. So that is something which is important. Even after you treat the peripheral cause, you need to follow these children because they can develop central puberty. Management, central precocious puberty is usually treated with GnRH analogs, and GnRH analogs are actually work by inducing desensitization of GnRH receptors and that thereby causing medical gonadectomy. And these can be used in depot formulations, which is intramuscular once a month or 3-month formulation. Height benefit is only when it is started early, but we have to also consider that when you are dealing with young children with central precocious puberty, they may have physical development of an advanced age child, but their mental age is actually corresponding with their chronological age. So they are at high risk for sexual abuse, and this needs to be considered a good sexual education and sensitive, which is to be administered in a sensitive manner, is very essential. You need to consider psychosocial factors and parental anxiety before starting the treatment, because these may be indications for starting treatment in certain groups of individuals. For patients who cannot afford GnRH analogs, you can use medroxyprogesterone acetate as an intramuscular preparation, but this does not offer height benefit. If there is hypothalamic hamartoma with central precocious puberty alone, surgery is not needed unless there is intractable seizures or there are features of raised intracranial tension. We usually monitor height, weight, the pubertal progression or regression, bone age, and sex steroids and LH basal or stimulated following initiation of therapy. For peripheral cause, you treat the cause, for example, treat the ovarian tumor, treat hypothyroidism, and that's enough. But if there are other causes like McCune-Albright syndrome, ovarian cyst, you may want to introduce aromatase inhibitors such as letrozole. And in boys, we go with androgen antagonists such as spironolactone or and aromatase inhibitors such as anastrozole. Again, you need to monitor height, weight, tenor staging, bone age, and sex steroid levels in these patients. So I'll give two case examples and then I'll end. So this is a case of 8-year-old female who had presented to us with breast development and pubic hair for last 1 year and had episode of vaginal bleed 1 month back. Her height was 135 centimeter, which was between 75th to 97th centile. Mid-parental height was somewhere near 50th centile. She was B4. There was no features, no history suggestive of CNS symptoms. Her LH at basal level was itself 1.29 international units per liter. So we didn't stimulate this child with GnRH agonist, and we were confirmed that she has central precocious puberty. Bone age was advanced. Uterine length was clearly more than 3.5 centimeter. ET was 4.2 mm, and ovary showed bilateral multiple follicles. We started leuprolide after discussion with family, and we had to follow this child till the time with the parents are satisfied that she's at an appropriate age for entering into puberty. And this is another case of a 4-year-old female who had breast development for last 2 months, and within 1 month of breast development she started at spotting, and next month she had a frank bleeding for 5 days. When we examined, she had breast stage B2, and on close clinical examination we found these irregular shaped macular hyperpigmented lesions which are suggestive of K-Failure macules. This was also seen on the forehead, and so diagnosis was McCune-Albright syndrome. Her ultrasound pelvis showed an ET of 6 mm. Uterus was pubertal. Thyroid function tests were normal. We did a bone scan because fibrous dysplasia could be a third manifestation of McCune-Albright syndrome. As we see, E2 is very high, LH is suppressed, bone age is advanced. We even did a GnRH agonist stimulation test, which was pre-pubertal, and patient was diagnosed to have McCune-Albright syndrome, managed with letrozole. And on follow-up, there was arrest of progression. There was no entering into the central precocious puberty, and E2 remained at less than 5 picograms per ml. So to summarize, an approach to precocious puberty: first, you have to confirm that there is sexual precocity. Then you have to confirm that there is, whether you are not dealing with any variants of puberty which are usually monocomponental and which are non-progressive, or whether you are dealing with precocious puberty. If you confirm that this is precocious puberty, we need to see whether this is central or peripheral, and then you determine the cause, whether the cause for central precocity is an organic or idiopathic cause, or whether the cause for peripheral precocity is an ovarian tumor, ovarian cyst, or hypothyroidism, and you plan the treatment accordingly. Thank you so much.
Thank you, Dr. Alpesh. This was indeed a very informative talk. And with the help of these two case scenarios, you made it very easy. I will ask you one very simple question. It may be very simple to you, but often we clinicians as gynecologists, we face difficulty. What X-ray would you advise to assess the bone age?
Okay, ma'am. For bone age estimation, we advise X-ray left hand with wrist. And that left hand with wrist X-ray should include all the phalanges, including the distal phalanges and tips. So that is the usual, and left hand is by convention. There is no hard and fast rule why we advise left hand, but typically by convention we advise X-ray left hand with wrist for bone age estimation. And
then what exactly should we be looking there for?
Ma'am, we should be looking at the at the maturation of epiphysis for all the phalanges actually, and we should compare it with what we do is we compare it with the bone age atlas, which is the Grulich's and Piles bone age atlas, which provides standards for boys and girls. And we compare, for example, if you have bone age of 10 years, so that photograph is provided in that atlas, and you compare the patient's X-ray with that bone age atlas, and you determine what is the bone age. That's how we compare.
Thank you. Thank you. Thanks once again for this very nice talk.
Thank you, ma'am.
I think we can move on to the next speaker now.
Yes, yeah,
I think
yes, Dr. Nitya, I'm there.
Please
Please
introduce
display
our
the slide for next speaker. So, good afternoon, everyone. And our next topic is on anovulatory PCOS. And the speaker is Dr. Chandan Kachru. She is my dear friend, is a consultant in Obs and Gynae at Adolescent Health Specialist at Pratiksha Hospital, Gurgaon. And she is affiliated to all major organizations, FOGSI, GOGS, Haryana OBG, and many others. Her major achievements is that she is a master trainer and lots of honors like Master Course Adolescent Health from Imperial College London. And she has been awarded Lukman for contribution at Adolescent Health. And you know that PCOS is very common nowadays. It is a very bundling problem, and we have to catch it early and have to start treatment very fast. So Dr. Chandan Kachru will enlighten us on the subject. So over to you, Dr. Chandan.
Thank you, Dr. Shashi, for a very, very sweet introduction. And it's my pleasure to be here. So I'll be talking on adolescent anovulatory PCOS, and it's a pleasure to be here with all the stalwarts of Delhi NCR. Polycystic ovarian syndrome, as you know, So everybody knows everything about this PCOS, and nothing very, very new, but few slides you might find a little bit different because the new guidelines have come in 2020 with so many organizations together in Australia. So a little bit difference. Otherwise, everybody knows everything about it. So polycystic ovarian syndrome is the most common endocrine condition affecting between 8 and 13% of women of reproductive age and 6 to 18% of adolescent girls. That's a huge amount, depending on the diagnostic criteria used and the population studied. We know the pathophysiology is both genetic and environmental factors contribute to its development, and inheritance is said to be both X-linked and autosomal dominant. In most cases, there is a familial clustering in female siblings and a positive family history of diabetes. We know that all these factors have a very strong association with PCOS, the lifestyle environment, the neuroendocrine environment, genetics, and definitely obesity. So there are many postulates for the development of PCOS in adolescents. Defect in insulin receptor genes has been demonstrated in few patients with PCOS, leading to insulin resistance and hyperinsulinemia. And hyperinsulinemia results in hyperandrogenemia and dyslipidemia. There's a disordered hypersensitivity of pituitary to the secretion of GnRH, and this results in increase in secretion of both LH and androgens from ovary. This causes oligoanovulation and hyperandrogenism. And androgens are converted, as we know, into estrogens that further augment pituitary hypersensitivity to GnRH. Obesity is associated with PCOS, and it leads to insulin resistance and hyperinsulinemia. So adverse this is very important slide because here we can catch it at a very nascent stage. Adverse intrauterine environment due to maternal undernutrition or anemia may result in neuroendocrine dysregulation in the fetus, leading to insulin resistance and intrauterine growth restriction in babies. And IUGR babies may develop features of PCOS in adolescents, especially if they have rapid weight gain in infancy and childhood. And here we can catch them and have an eye on their obesity. Rapid weight gain exacerbates the existing hyperinsulinic metabolic state in these children. So these days we are talking a lot about epigenetics, and epigenetics in PCOS has a role, And there are two sensitive periods. First is the intrauterine environment, where the psychological stressors have a very important role in producing changes in the meiotic prophase. And in the peripubertal and adolescence age, where definitely the second meiotic division gets definitely later on, when once they produce, they are in that fertility age group, that psychological stresses have to be taken into consideration and are being studied a lot recently. Now, regarding the history, as we know that adolescents have to be dealt with very sensitive and empathetic nature, and during this history taking, we have to be very sensitive and empathetic towards them. HEADS is a very important acronym which you have to use while taking a detailed history of the adolescent. It is a psychosocial history, which is very important and has to be taken in privacy with the confidentiality. HEADS stands for various domains of an adolescent life. H stands for home, E for eating and education, A for activities, whatever she's doing, day-to-day activities, drugs, suicide, depression, and sexuality and safety of the adolescent. You might get a lateral entry to the problems of the adolescent. Dietary intake, level of physical activity, details of media usage, body image concerns, bullying and teasing by peers, difficulty in sleep, snoring, and features of depression and anxiety should be elicited. Eating disorders and disordered eating both may coexist with PCOS and should be asked for in particular. Menstrual history is very important, and birth history regarding IUGR, as I told you, is very important. Now we come to the diagnosis, and diagnosis of PCOS during adolescence is both controversial and challenging due to the overlap of normal pubertal physiological changes and with adult PCOS diagnostic criteria. The definition of irregular menstrual cycle and PCOS has changed. So according to the normal Rotterdam diagnostic criteria, we know that two of the oligoannulation, clinical or biochemical hyperandrogenism, and polycystic ovaries done by the ultrasound are important. But in adolescents, we do not know the etiology cannot be, the ultrasound has ultrasound is not recommended in diagnosis when less than 8 years post menarche. So till 8 years of post-menarche. So definition of irregular cycles is little different here. So less than 1 year post-menarche is different. There is no irregular menstrual cycles, are absolutely normal. More than 1 to less than 3 years post-menarche, less than 21 days or more than 45 days is supposed to be the irregular menstrual cycle. More than 3 years post-menarche, less than 21 days or more than 35 days or less than 8 cycles per year. More than 1 year post-menarche, more than 90 days for any cycle, and primary amenorrhea by age 15 years or 3 years post-telarche. So there are now the diagnosis, how we do with the clinical hyperandrogenism. A comprehensive history and physical examination should be completed for symptoms and signs of clinical hyperandrogenism, which in adolescents includes severe acne and hirsutism. Mild comedonal acne is common in adolescent girls, but moderate or severe comedonal acne, that is 10 or more facial lesions in early puberty, or moderate to severe inflammatory acne during the perimenarcheal years is uncommon. We see only less than 5% and is more likely to relate to clinical hyperandrogenism. So standardized visual scales are preferred in case of hirsutism, and which is the second most important clinical condition, and such as we use the modified Ferriman-Galvez score with a level of more than 4 to 6 indicating hirsutism depending on ethnicity, and acknowledging that self-treatment is common and can limit clinical assessment. Now we come to the biochemical estimations. So calculating free testosterone, free androgen index, or bioavailable testosterone should be used to assess biochemical hyperandrogenism in the diagnosis of PCOS. So DHEAS and androstenedione provide limited additional information in the diagnosis of PCOS. However, they could be considered if total or free testosterone are not elevated. So androstenedione and DHEAS are more useful in excluding other causes of hyperandrogenism. And pelvic ultrasound, according to the 2020 new guidelines, adult PCOS criteria have been derived from transvaginal ultrasounds, which should be avoided in females not yet sexually active. Pelvic ultrasound should not be used for diagnosis of PCOS in those with a gynecological age with less than 8 years post-menarche. due to the high incidence of multifollicular ovaries in this slide, which I've already told you. And although pelvic ultrasound is not indicated for PCOS diagnosis in adolescents per se, it can be used to investigate other possible uterine or ovarian abnormalities in adolescent girls, such as those that present with primary amenorrhea. Now, which are the investigations which are not recommended? Till date, AMH is not recommended. And there is an emerging evidence that with improved standardization of assays and established cutoff levels based on large population of different ages and ethnicities, AMH assays will become more accurate in the detection of polycystic ovary morphology. Now, the diagnosis of PCOS is definitely a diagnosis of exclusion. So the most important thing which has to be excluded is the pregnancy itself. Non-classical congenital adrenal hyperplasia, deficiency of 21-hydroxylase due to mutations in the 21-hydroxylase gene is the most common type. Hypothyroid, so TSH has to be done. Hyperprolactinemia, prolactin has to be done. Glucocorticoid excess due to Cushing's disease has to be ruled out. Glucocorticoid resistance acne and androgen-secreting ovarian or adrenal tumors can cause menstrual irregularity and hyperandrogenism. So they have to be ruled out. Here it's a very important point is this section is that the adolescents who have features of PCOS but do not meet the diagnostic criteria, the at risk of PCOS label could be considered here, and reassessment is advised at or before full reproductive maturity. This timing is at 3 years post-menarche in relation to menstrual cycle irregularity, and at 8 years post-menarche in relation to the use of pelvic ultrasound to identify a polycystic ovarian morphology, so that we do not miss these children, which later on they may land up in infertility. Anxiety and depressive symptoms should be routinely screened in all adolescents and women with PCOS at diagnosis, and body image issues may be addressed. According to recent but limited data, cognitive behavioral therapy may be beneficial in terms of weight loss and symptoms of anxiety, depression in both adolescents. This is a table which we can use even in our clinics to make the adolescents understand that what are the long-term sequelae of PCOS. They range from premature anarchy to adolescent PCOS to GDM, infertility and preterm labor during the antenatal period, and psychosocial issues, and the cardiovascular disease and endometrial carcinoma in the later stages of life. Psychosocial issues which will remain from the early years to late years is very important. Diabetes, metabolic syndrome, obstructive sleep apnea, and non-alcoholic liver diseases is also a long-term sequelae. Now the treatment, everybody knows that lifestyle interventions are the most important treatment modality, and preferably multi-component, including diet, less sedentary behavior, exercise, and very importantly, behavioral strategies. This point we always miss, the stress factor. Should be recommended in all those with PCOS and excess weight gain to achieve reductions in weight, central adiposity, and insulin resistance. Additionally, weight gain escalates from adolescence and early adulthood, requiring early vigilance and interventions, so that there lies that catch them young. So a 5% reduction in body weight is associated with an improvement in both metabolic and reproductive health markers, as well as with psychological benefits. At least 60 minutes, 3 times per week of moderate to vigorous physical activity, including muscle and bone strengthening exercises recommended. The low-fat DASH diet has been proved to be effective in obese women with PCOS. This DASH diet contains mostly low carbohydrate and a protein diet, which is very low fat. And these days has been taken for all the metabolic disorders. Proved to be the best diet for all the metabolic disorders. The low glycemic load and glycemic index of the diet had positive effects on the cardiometabolic and reproductive profile of the adolescent. Studies showed that insufficient fiber intake in PCOS is important for the incidence of insulin resistance and cardiovascular disease and reproductive functions, and that consumption of saturated fat and cholesterol adversely affects the metabolic profile typical for PCOS. Now, the pharmacological principles are that we know that the use of combined oral contraceptive pill should be considered in adolescents with a clear PCOS diagnosis, or could be considered in those deemed at risk but not yet diagnosed with PCOS in very special group and for the management of clinical hyperandrogenism and irregular menstrual cycles. And contraindication of OCP pills, as we know, the WHO has its guidelines like history of migraine with aura, deep vein thrombosis, pulmonary embolism, multiple risk factors of cardiovascular disease and breast cancer. Smoking and obesity are also risk factors for deep vein thrombosis. However, the absolute risk of these complications in adolescents remains very low because the smoking and obesity are the things we see more in most of the adolescents. So we can consider even then the use of OCPs. Here also in another practice point is that the COCPs with 35 micrograms of ethinyl estradiol and cyproteron acetate should not be used as first line therapy due to the absence of evidence of greater efficacy and the presence of higher risk, especially deep vein thrombosis. So we can consider lower risk COCP preparations as a first line therapy. Now, combined COCP and metformin in combination was considered in adolescents with PCOS and a BMI of more than 25 kg per meter square, where the COCP and lifestyle changes do not achieve desired goals. Although the combination was very good and had additional benefits, these did not surpass the impact of COCP plus lifestyle intervention. Only when they fail, then you can use the metformin. Metformin, in addition to lifestyle interventions, should be considered in patients with clear PCOS diagnosis or with symptoms of PCOS before a diagnosis is made. There was also a meta-analysis that evaluated metformin versus COCP in adolescents with PCOS, which included 4 RCTs, and it showed that metformin at a dose of 1700 to 2000 milligrams per day was associated with an improvement in BMI when compared to the COCP. Now, anti-androgens recommendations suggest the use of COCP alone with cosmetic therapy for at least 6 months prior to considering the anti-androgens, where COCPs are contraindicated or poorly tolerated and presence of effective forms of contraception. Anti-androgens could be considered to treat hirsutism or androgen-related alopecia. Now, this is a new treatment, the bariatric surgery, and it is recommended for morbidly obese adolescents with BMI of more than 35. With metabolic complications after they have attained Tanner stage 5 and have had a poor response to therapeutic lifestyle change and pharmacotherapy for at least 6 to 12 months. The myoinositol in the treatment of teenagers, we had many studies were there, and one of the studies did compare the effectiveness of myoinositol and OCPs, and this study did show that it is safe and effective method to prevent and correct metabolic disorders in teenagers affected by PCOS. With combination of myoinositol and OCPs, anti-androgenic effects are enhanced, negative impact of OCPs on weight gain is balanced, and metabolic profile is improved. This was an Indian study from AIMS, and it also, the results were very encouraging, and it showed that myoinositol and D-chiro-inositol in combination are effective in regularizing menstrual cycles and improving insulin resistance. Now, sometimes we are in a dilemma, nothing is working, so can we give cyclical progesterone on treatment as a treatment of adolescent PCOS? Cyclic progesterone provides predictable withdrawal flow and symptom relief, but also decreases LH and androgens. Although non-randomized controlled studies of single cycle progesterone therapy are available, there is no evidence that longer duration cyclical progesterone reverses the clinical or metabolic PCOS disturbances. Longer studies and RCTs are needed. Studies did show ovulatory disturbances, androgen excess, and E2 and P4 imbalance are central to androgenic PCOS, and cyclical therapy by slowing GnRH pulse rate may improve both PCOS symptoms and fertility. So the take-home message is that proper diagnosis of adolescent PCOS is important to avoid overdiagnosis. Long-term consequences are important to understand the importance of catching them young. Epigenetics of adolescent PCOS is to be understood in its right perspective to avoid metabolic disorders in later part of life, and correct pharmacotherapy and lifestyle management are the pillars of the treatment. There is one thing which is indeed lean adolescent PCOS, which is still a challenge, and more research needs to be tackled that effectively. So multidisciplinary approach of the adolescent and treatment of their PCOS is very, very, very challenging, and it should be dealt up with their customized approach. Thank you so much for inviting me in this wonderful webinar. Thank you.
Thank you, Dr. Chandan. It was a brilliant talk. You have touched every point of PCOS so nicely. And especially I liked that slide, that type of menstrual irregularities post-menarche. It was a beautiful slide. I have taken a screenshot of that.
Thank you so much.
And lifestyle, yeah, definitely. We have to catch them early. And sometimes, you know, the time period of developing a PCOD and having the first 2 years of irregular menses because of non-developed hypothalamic pituitary axis, that time period is very small, and we cannot understand when the patient is having it is because of hypothalamic pituitary effect or due to PCOD. So it is very important to catch the PCOD disease at that particular time and intervening and making some interventions. And second thing, I'm just sharing my one experience. You know, when we tell our girls to do exercise, they say they are busy with study, this and this routine. So I just tell them in which college or school you are going and how far is that school or college from your place. They say 1.5 kilometer, 1 kilometer, 2 kilometer. I just say that you go walking, come walking. Don't take a rickshaw. Don't tell your papa to take a car. So this is how we can
very practical approach. Yes,
very practical approach within their own time style, own lifestyle. We can start their management. This is very important.
Yes.
So thank you so much for such a brilliant talk. And you can display Dr. Leena Badwa's slide for our next talk. So Dr. Leena Badwa's topic is fertility preservation in adolescent. And she is a great academician. I know her since last 20 years. Once upon a time, I worked with her. And she is MD, DNB, NMNAS, and FICOG. Presently, she is professor and head of the Department of Reproductive Medicine and Surgery, ESI, PGI, MSR, Basai, Darapur, New Delhi. She had fellowships, FOGSI Ethicon in the field of endoscopy, and FOGSI Dr. Vasant Benchai, overseas scholarship, reproductive medicine, endoscopy, born in Kiel University, Germany. She is also trained in embryology and recipient of Kamini Rao. She had given Kamini Rao oration and many more accolades to her. And I invite Dr. Leena. Now the stage is yours. And I welcome you.
Hello. Am I audible?
Yes, you are audible, Dr. Leena. Yes, you are audible. Good afternoon.
Dr. Shashi, for your kind words, and happy to meet you all online. And today I have been given a very important topic to speak, and it's close to my heart also, and very apt and very well chosen topic, which is need of the hour. Just a minute, I'll do it full screen. Yeah. Okay. So why we are talking today about fertility preservation? We know that the number of cancer cases is increasing, and in India, the estimated number of people living with cancer in India is about 2.5 million. And moreover, the incidence of cancer in adolescents and young adults, that is increasing. So that's a concern. And if we have a look at this cancer registry, this
Ma'am, your slides are not moving.
Okay, I've gone to the next slide. I'll just see.
Dr. Leena, on the left-hand side below your screen, see there is one button. You can press that. Try to move it. It will move again.
Yeah. Okay. Now I'm trying to move it.
Yeah.
Click on the slide once.
Okay. Yeah. It is moving now.
Yes. The slide has changed.
Yeah. Okay. Thank you. So basically, I wanted to show this cancer registry. This is 10-year cancer registry, which has been published in Lancet Oncology Journal, and which they have looked at the cancers, different type of cancers in different areas of the world, and they found that in the age group of 9 to 15 years, the leukemias and lymphomas, they are quite common. And also the epithelial tumors and melanomas, they are common in this particular age group. So paralleling this, the 5-year survival rates have markedly improved due to development of better chemotherapeutic agents, oncological surgeries, and radiotherapy. So let's have a look what is the effect of chemotherapy when we are using for these cancer patients on the gonadal function. Now, we know that in Hodgkin's lymphoma, we use combination therapy. That is the commonly used as vincristine and other drugs. These all drugs, they have high chance of sterilizing the patient. And recovery of spermatogenesis will depend on what the type of drug and what the regime is being used. And cyclophosphamide is the one most commonly used alkylating agent in pediatric cancer treatment, and it is highly toxic, and especially to the gonads. So if you have a look at this chart, which depicts the drugs being used for the treatment of cancer. So all these drugs, they have an effect and cause impairment of spermatogenesis. And similarly, the same group of drugs, they also affect the ovarian function. And especially if you're talking about prepubertal age, in that particular period also, if chemotherapy is given, it has an effect on prepubertal gonads also, like as it is detrimental is later in life. And let us have a look about the effect of radiotherapy on gonads. The testes in males, it is very sensitive to irradiation, especially the germ cells. Even a dose more than 4 gray can cause permanent damage to germ cells. And for lytic cells, the dose more than 20 gray is needed to produce hypogonadism. And especially whole body irradiation when it is used before bone marrow transplantation, that involves the testes. And testicular irradiation when it is being used to treat carcinoma of the testes, it is associated with high rate of permanent sterility. And even if we look at this particular chart, radiotherapy also damages ovarian function, particularly in age group of 15 to 20 years in dose more than 9 gray. So the deleterious effect of chemotherapy and radiation, that is well documented. Even the cancer itself has an effect on the semen parameters before treatment. So if we look at all these gains in survival after chemotherapy, after radiotherapy, they all call for attention to the fertility preservation aspect. And even the American guidelines, ASCO 2018, it also mentions that the problem of infertility, it should be addressed in these young adolescent cancer patients, and all the care providers, including the medical oncologists, radiation oncologists, gynecologists, urologists, hematologists, pediatric oncologists, surgeons, whoever is dealing with such kinds of cases should address this problem, and they should refer the patient to reproductive specialists as early as possible, and especially before the start of the treatment. And even another discussion or referral may be necessary when the patient returns for follow-up after completion of therapy, or if pregnancy is being considered. And very important is that all these discussions should be documented in medical records. And what all comes as a part of onco-fertility counseling is one needs to discuss about the current or future family desire, their health and prognosis, what will be the potential impact of the disease or the proposed anti-cancer treatment on their fertility and gonadal function, which I have already discussed, the chances of future conception, pregnancy outcome, even the need for effective contraception. These all issues needs to be addressed as part of onco-fertility counseling. So once we are done with that, now let us have a look what are the fertility preservation strategies or methods available. In case of a male patient, male adolescents, when we are talking, who wishes to preserve fertility and is able to ejaculate by masturbation, then the sperms in the semen can be cryopreserved. And if he's having difficulty to ejaculate by masturbation, then assisted techniques like penile vibrator or ejaculator can be used. And in case there are no sperms in the semen, then one has to go for TZ or micro TZ for sperm cryopreservation. And in case of females, in adolescents who wishes to preserve fertility, If the time period available is more than 2 weeks, one can think of ovarian stimulation and go for oocyte cryopreservation. But if the time period is short, one has to go for ovarian tissue cryopreservation. And a word about GnRH analog, that the only pharmacological mean for protecting the ovaries from chemotherapy-induced injury is GnRH agonist, but its efficiency remains controversial. And the best technique which is available for adolescents is oocyte cryopreservation. It is advanced technology which is fully established now, and no partner is required, and oocytes can be easily cryopreserved. And another what I discussed is about ovarian tissue freezing, in which preparation of human ovarian tissue for cryopreservation is done. Now, as per ESMO guidelines 2020, one important point is that the fragments of ovarian tissue, they should always be analyzed for the presence of neoplastic cells with appropriate techniques before transplantation, especially in cases of acute leukemia, neuroblastoma, or any other solid tumor. Even the ASRM has removed the experimental label from ovarian tissue cryopreservation so that the pediatric research can continue, and this technique no longer remains experimental and can be used for adolescent females. Now, once the ovarian tissue has been taken, it needs to be transplanted back. It can be transplanted back to the original site, like by laparoscopy, it can be transplanted in the peritoneum of ovarian fossa or to the remaining ovary, and neovascularization occurs, enabling better tissue survival, although the process is invasive. And the orthotopic transplantation, it can also be done by open technique, and the ovarian tissue which has been removed can be transplanted back. And the other method is heterotopic ovarian transplantation, in which the ovarian tissue is transplanted at an alternative site, and the most common site is subcutaneous, either in anterior abdominal wall or forearm, as you can see in this diagram. And also in next, in which the pockets are made, subperitoneal pocket and anterior abdominal wall, and the tissue is transplanted back. And another one of the other alternative is that when a pelvic irradiation is performed, ovarian transposition can be offered. But in this, since there's risk of remigration of the ovaries, the procedure has to be performed as close to the time of radiation treatment as possible. So to sum up the recommendation, semen cryopreservation, it is effective, and healthcare providers should discuss sperm banking with post-pubertal males receiving cancer treatment. Hormonal therapy in men is not successful, and other methods such as testicular tissue cryopreservation and reimplantation or grafting of human testicular tissue should be performed only as part of clinical trials or approved experimental protocols. Although I have mentioned that ovarian tissue cryopreservation is now no longer experimental, but still testicular tissue cryopreservation, it's done as part of clinical trials. And even post-chemotherapy, men should be advised of potentially higher risk of genetic damage in sperms collected after initiation of therapy. Although one should not refuse, because nowadays we are doing FOGSI and very few sperms are required. Special consideration which we are talking about in children today, the suggested method, established method are semen or oocyte cryopreservation for post-pubertal children with patient assent and parent or guardian consent. And for pre-pubertal children, the only fertility preservation options are ovarian and testicular cryopreservation. Among this, the testicular cryopreservation is still investigation. So take-home messages: all cancer patients of pre-pubertal, adolescents, and reproductive age should receive complete oncofertility counseling as early as possible in the treatment planning process, irrespective of type and stage of disease. Involve multidisciplinary team of oncologists, hematologists, fertility specialists, and there's need for more awareness and early referral for particularly these young adolescent children. Thank you.
Chairpersons, please. Dr. Sangeeta, Dr. Deepti.
Dr. Shashi, ma'am.
Dr. Shashilata Kabra.
Dr. Shashi has messaged that she is busy somewhere.
Nupur, ma'am.
Thank you, Dr. Leena. It was very informative and updated talk. And thank you so much. So, now we
Can I add one thing here?
webinar.
Dr. Taru?
Yes,
Actually, I had done a lot of literature review when I was writing a chapter for adolescent FOGSI, this thing. You know, there are so many environmental pollutants which have been assigned, you know, they have been documented to be thieves of, you know, adult reproductive potential. So these endocrinal, they cause endocrinal problems also. So what is your opinion regarding that? And of course, smoking was discussed, alcoholism was discussed. They were, you know, also part of the discussion in previous presentation also. So what is your opinion regarding that? Because these may cause a decline in the reproductive potential of the adolescents and young adults.
Yeah, Dr.
So,
Anita, these are called endocrine disruptors. And
yes.
now I say you're very right. Because of the environmental pollutants, and also we have done a study on occupational hazards. Also, they contain these heavy metals like lead, mercury. They all have an effect on spermatogenesis, and because of that, the sperm count, motility, morphology is being affected. There have been various studies also on this.
So very nice presentation overall, Leena, as expected from you. And it was a great presentation.
Dr. Taru?
Yes.
Can I ask Dr. Leena, where in Delhi do we send the patient for ovarian cryopreservation? We have quite a few girls with bilateral ovarian tumors diagnosed recently after COVID. In fact, 2 of them who are going for chemo, and we were searching where to send them.
No, cryopreservation in India, I'll say it is not still well established technique, although AIMS, they have started clinical trials on this ovarian tissue cryopreservation. So you can discuss with them. We at our
in Delhi, I tried to search a lot of centers. I didn't get any response where to send the patients.
AIMS has recently started trial on this.
Okay, maybe I'll have to post. Okay, thank you.
I thank all the chairpersons and speakers for such an enlightening session. And for next panel discussion, which is on adolescent and its health problem, I would like to invite the moderators, Dr. Taru Gupta, who is a professor and head at ESI PGI MSR, and Dr. Divya Solanki, who are assistant professor at our department. Dr. Taru and Dr. Sanjana, Dr. Divya, please.
Thank you, Dr. Nupur. Now, coming to the last session, that is panel discussion.
Nothing. I'll just minimize this. We don't have to, because my slides nahi dikhengi, ma'am. Okay.
Myself and my co-moderators, Dr. Sanjana and Dr. Divya. I welcome all the panelists, Dr. Anita Rajoria, Dr. Rashna Agarwal, Dr. Niharika Deeman, Dr. Chetna Sethi, Dr. Taruna Dua, and Dr. Yashika Gudesar. We are lucky to have esteemed panelists and all our stalwarts and working hard in the field of adolescent health. So without wasting time, let us start with the panel. Let me introduce Dr. Taruna is a senior consultant at Akash Hospital and Venus Obs and Gynae Infertility Clinic. She is a chairperson. She is a treasurer of DGF Southwest Society. Dr. Niharika Deeman is associate professor at Maulana Azad Medical College. She is a member of different professional bodies, and she has held various positions in these bodies. She has been awarded with international awards at South Korea, Melbourne, and her contribution in different journals and books is immense. Dr. Yashika Gudesar is senior consultant at Manipal Hospital. and she has been awarded with Dwarka Doctors Forum Award. Welcome, Dr. Yashika. Dr. Rachna Agarwal is Professor, UCMS and GTB Hospital. She was Joint Secretary, AOGD 2011 to 12, Joint Secretary, NACHI from 2014 to 16, and she has numerous publications to her credit. Dr. Chetna Sethi, she is Nodal Officer for One Stop Center at Loknayak Hospital. She received Dr. Sunita Mittal Gold Medal for the best paper, and she has numerous publications in journals and different books as author. Dr. Anita Rajoria is chairperson of Adolescent Health Committee, AOGD. She is member of DGF Southwest Society, and we have listened her, and she needs no introduction. She is doing a great work. Welcome all the panelists. Now, coming to the first case, Dr. Taruna, this case is for you.
Yes.
A 17-year-old girl with primary amenorrhea. She had normal growth and pubertal development. There was no complaint of cyclical abdominal pain. She was average in school, not involved in athletics, not taking any medication, no family history of delayed puberty. She was a thin young girl with BMI 17.3 kg per meter square. Her gait was normal, spine was grossly normal, no galacturia, breast Tanner stage was 4, axillary and pubic hair were present. On inspection, the vulva was grossly normal. There was blind ending vaginal dimple, 2 centimeters in length, with normal external urethral meatus. On per rectal examination, a good tone of anal sphincter was there, and uterus and cervix were not palpable. So what investigations would you like to order for this patient?
Yeah, so taking into account the history, I would like to narrow down a little in my mind what I am heading towards. So there are a few things which are quite informative as to she had an average height, her breast development, that is thelarchy and adrenarchy are present, and examination showed an absent uterus. So there would be a few leading investigations which I would like to do in this patient are, like I would like to do her FSH levels in particular, her estradiol levels in particular, and I would like to get an ultrasound done for her to confirm the absence of the uterus, the ovaries, and the status of vagina, whether there is a dilatation hematosuggestive of any hematocolpus. So these very few investigations will help me to narrow down. And also, yes, in blood investigation, the testosterone levels again would be very helpful to confirm my diagnosis.
So, okay, very right. We proceeded with the 2D ultrasound, and uterus was absent, ovaries was normal as per that age, kidneys bilaterals were normal, and no other concomitant defects were identified.
Right.
And hormonal profile, TSH, prolactin, FSH, and LH were ordered, and they were in the normal range. And since the uterus was absent, we had proceeded with karyotype estimation, and it was 46XS normal. MRI confirmed the diagnosis suggestive of complete uterine agenesis with bilateral rudimentary uterine analgin with no endometrial cavity. So the diagnosis of Bayes Rokitansky-Kusser-Husser syndrome type 1 was made. Bilateral kidneys were normal and no other concomitant defects were identified. So how do we define primary amenorrhea and when to start evaluation for this condition?
Yeah. According to the latest definition as is given by Eshrey also, we define primary amenorrhea as the absence of menstrual cycle in absence of secondary sexual characters by age of 13 or absence of menstrual cycle by age of 15, even in presence or absence of the menstrual secondary sexual characters. One more thing that has to be taken into account would be that the patient needs to be evaluated for primary amenorrhea if she has not started her menstruation even 3 years after thelarchy or 5 years after thelarchy if that has occurred before the age of 10 years.
Very right. Thank you. And what is the most common cause of primary amenorrhea, Dr. Taruna, and what are the other anomalies which can be associated with MRHK because we need to assess for them?
Yeah. Yeah, so as the data has provided us, the most common cause for primary amenorrhea, as we have seen, is the gonadal dysgenesis, that is associated with Turner's syndrome. That is the most common. And the second most common is the Mullerian aplasia, that is Mayer-Rokitansky-Kushner-Hauser syndrome. That is the second most common cause.
Okay, so now since we have confirmed the diagnosis with MRI that she is a case of MRKH type 1, how should we manage this case? Whether we should proceed with the non-surgical method or the surgical method, and at what age we should start the procedure? What is the ultimate aim which we are building?
Yeah, the case we are discussing in this, the girl is of 17 years of age. So anyways, we need to start the treatment for her because she has crossed the limit of 15 years also in the presence of secondary sexual characters. So the most important thing is that after our investigations, once we have narrowed down our diagnosis that she is a case of the MRKH syndrome, what are the future things that we have to keep in mind, and accordingly we have to guide her. So the first and the foremost more important thing for her, I think, is going to be a psychological support, because many patients, such patients will experience a lot of anxiety, depression, and they will question their female identity and grieve their infertility. These patients always struggle with how to share their conditions with their family members, with their peers, and with their romantic partners. Number two, having support from the peer group is going to be very helpful for them, because knowing other people who are in a similar situation gives them a lot of courage. Number three, we have to do the definitive treatment. After all, what do we want to achieve for such patients? We know they are not having the uterus, they are not having the uterus and cervix, but the gonads are present. But due to the absence of vagina, they will not be able to have sexual activity. So there are two things of main concern. Number one, to have a vagina so that they can have a normal sexual activity with their partner, and number two, their fertility issues. So about the vagina, the first line of approach for these patients is what is considered more safe and more patient controlled, more cost effective, is the vaginal elongation method by using the dilators. And although it's a very successful approach, many of us also as obstetricians and gynecologists, we actually do not have enough experience in primary vaginal dilatation and may not feel very equipped to counsel and coach these patients adequately. So for these, we should be referring them to those centers where those people have enough of experience. So coming to the part of vaginal dilatation, we have to guide our patient very nicely in this. In such cases, we would like the patient that she should have a thorough examination with a mirror so that she can identify her clitoris, her urethra, and distal. She should be able to understand and demonstrate the appropriate location and angle to place the dilator. She should be instructed to place progressive dilators on the distal vagina apex for about 10 to 30 minutes, 1 to 3 times every day. There are many dilator options available, and the patient may want to try different dilators or vibrators to determine which one are most comfortable for her. And also, she would need the help of an experienced pelvic floor therapist who would guide her time and again. And there is no set length of vagina which has to be achieved before the penetrative intercourse is permitted. And indeed, the elongation by vaginal intercourse alone can also be successful. So here I would like to say that there are a few risk factors for having poor results after vaginal dilatation, which are poor motivation. It could be an unstable relationship with a partner, an interpersonal conflict, parental misunderstanding and diagnosis, socio-cultural factors, mental health issues, most of which are not anatomic and may predict a poor adherence to the postoperative dilatation. So lack of privacy also adds a lot. Limited ability to travel to the clinic for close follow-up, lack of motivation, uncertainty that dilatation would be unsuccessful, and perception of dilatation as a negative experience.
She has tried for dilator. Yeah. She has tried for dilator, but it was not successful. So what next?
So next,
and at what age?
See, the vaginal dilatation is 90 to 96% of the cases, we expect that vaginal dilatation can be successful. Surgical options are given to those patients who themselves take up this option, who are mentally prepared after addressing all these issues to the patient and her family members. And once the patient is mentally ready to take up this and grown up enough emotionally to take up this surgical option, only then we go ahead for a surgical option for this patient.
So practically, we have all seen Mackendo, and we have all done Mackendo neovaginoplasty in our all hospital centers. But the latest Williams vaginoplasty, Vecchetti vaginoplasty was also being practiced. Sigmoid vaginoplasty is definitely not, we have not seen, and it's just a theoretical importance. And nowadays it is modified laparoscopic Davidoff-Colpocoisis procedure, which is gaining much popularity, and it has good results. It has a quick procedure, laparoscopic procedure. So can you tell something about Davidoff procedure? What are the advantages?
Davidoff procedure, it is being done quite commonly now. It was developed as a 3-stage operation, which requires dissection of the rectovesicular space with the abdominal mobilization of a segment of peritoneum and subsequent attachment of the peritoneum to the introitus. And other vaginoplastic graft options are also available, which might include the bowel or the buccal mucosa, the amnion, and various other allografts can be used.
So this is a peritoneal pull down technique. It is done through laparoscopic approach and 3-stage procedure. As you said, we create a space between the urethra and bladder anteriorly and rectum posteriorly, and the peritoneum is mobilized and sutured to the edges of vaginal vestibule. Definitely the post-procedure patient needs dilatation. Post-operative dilatation is required. The advantages are of this procedure: it is a simplest, safe, quick procedure, good lubrication because it is the peritoneum lining, it secretes fluid. So it has satisfactory results. There is lack of granulation tissue, there is absent scar, less bleeding, less post-operative pain, shorter stay, quick recovery, and a satisfactory cosmetic outcome. Now coming to, we have made the vagina, she is now sexually active. How to address this fertility issues in such patient?
Now, the fertility issues, it becomes very important to assess the fertility issues. The understanding the future fertility options allows these young women to understand their potential for becoming parents, which will help them cope with the diagnosis and its implications. So I think we can say that there are 3 major options which are available. Number 1, the simplest one is we can suggest that you go ahead for adoption. Number 2, gestational surrogacy is also a very good option for her because she has gonads. She can, the ovum pickup can easily be done, and using the ART techniques and a surrogate mother, she can have a child with the gametes of the same parents. So that is a very good option. And the third next one is of uterine transplant, which we have been seeing, but yes, we do not still have, I think, enough data to be very confident in offering this kind of approach, and yes, also the cost and the accessibility involved. So I think the first 2 options are more better options for the patient.
Definitely, very true. One of the uterine transplantation was done by Dr. Putembagar at Pune, and a female baby was delivered also. Of course, the section was done after 1 year of this transplantation. So just to share this information. Thank you, Dr. Taruna. It was wonderful interacting with you. Now coming on to the next case, Dr. Niharika Devan. Please, this is for you.
Yeah.
Okay, Niharika. Yeah.
Hello, good afternoon.
Good afternoon. So 18-year-old unmarried girl, she reported to gynae casualty with complaints of pain lower abdomen since 1 month. It was increasing in duration. Initially, it got relieved with NSAIDs, but not relieved since last 1 week. Not associated with fever. There was no history of any change in bowel or bladder habit. She achieved menarche at 14 years of age and had regular cycles with flow lasting for 3 to 4 days, occurring at a 30-day cycle. She was actually inactive. She was average built. BMI was 20 kg per meter square. Vitals were stable. Thyroid, breast were normal. On local examination, per abdominal examination, there was 14 weeks firm mass arising from pelvis, non-tender, no other organomegaly. Local examination was normal. So how would you investigate this girl? And what are the differentials of a young girl with 14 weeks firm mass?
Yeah, thank you, Dr. Taru. I think it's a very informative case that you have put in. And
all these are real cases, Dr.
Yeah.
Yeah.
So, this is not an uncommon scenario, getting abdominal mass in adolescent. So whenever an adolescent girl approaches with the abdominal mass, which is abdominopelvic mass, rather, I would say. So I think first and foremost at 18 years of age, when she's already attained, she's, menstruating, and also pregnancy should be ruled out first and foremost. And, seeing the clinical history, so abdominopelvic mass, mostly they say that the most common abdominal mass in a adolescent girl is arises from the ovaries. So I've already said pregnancy has to be ruled out, full bladder has to be ruled out. So common is the ovarian mass. So basically, whenever we are talking about a 14 weeks mass, which is firm in consistency, so it can be either a benign mass, which could be a simple follicular cyst, or a dermoid cyst, that is the mature teratoma. And when we talk about malignancy here, which constitutes per se only 8% of all the ovarian malignancies at this age group, then the first and foremost common one, germ cell tumors stand the commonest one, in which we have the dysgerminomas first, and followed by the teratomas. And one more thing I want to highlight here, that even non-gynecological causes are of very important in this age scenario. As you've already highlighted that there was no fever. In case there's a history of fever, tuberculosis, and appendicular lump. And for appendicular lump, it has been seen that the non-conference with the pre and post-operative findings in cases of an ovarian mass is as high as 22%. So we need to rule out these masses also. So coming on to the ovarian endometrioma, though it is a age group is 18 years, it would be down the list, and to ovarian abscess in case of fever, discharge, or any infections, and juvenile granulosa cell and GI masses, they come down the line. Yeah, and for investigating such masses, just one more thing I wanted to highlight here, that parovarian masses are also very common, which we have seen in such age groups, and even large parovarian cysts have also been documented. We recently did a large, around 16-week size abdominopelvic mass, which turned out to be a parovarian cyst. So for investigations, basically what we need to do is we need to do a thorough clinical examination, which will rule out any virilizing or feminizing sex-caused tumors. And then we need to rule out tuberculosis and other surgical masses. As for blood investigations, apart from the routine blood investigation, we need to run the battery of the tumor markers. And per se, when we're suspecting a germ cell tumor, alpha fetoproteins, HCG, LDH, CA125, CA19-9, and CEA, estradiol, testosterone levels are very good markers to differentiate broadly between epithelial, non-epithelial, and further subdivide it into the type of germ cells according to the markers which we have. So do we talk about radiological investigations after this, or imaging?
No, first the ultrasound will be done first. No, ultrasound was done for this patient, and it showed a complex adnexal mass of 8 into 9 centimeters on the right side with normal uterus. Calcification was there, and there was low resistance flow. It was the MRI was suggested, and the findings were suggestive of 8 into 9 centimeters solid cystic lesion. Right ovary could not be visualized separately, and the impression given was malignant ovarian tumor, probably immature teratoma. So the tumor markers were advised for this patient, and the reports were suggestive. Alpha fetoprotein was increased, 165. LDH, beta HCG were normal. CA125 was 135, and CEA was 12. So these are the investigation, imaging, and tumor marker reports. So now, how would you counsel and manage this patient?
Yeah, so as the tumor markers as well as the ultrasound and MRI points towards a malignant mass. So a counseling should be done by a multidisciplinary team involving an infertility specialist, also endocrinologist and oncologist, definitely. So in this approach should be more of a minimal approach or a minimal staging approach. And we need to tell the patient that if it turns out to be malignant, histopathological examination. So we need to do a conservative approach in this to remove her ovaries. We need to do a unilateral salpingo oophorectomy. That has to be counseled. So basically we need to go ahead with the frozen and proceed frozen section and proceed type of a surgery. And in this, basically, the procedure opted is the unilateral salpingo oophorectomy with a minimal staging laparotomy. In this, basically, for germ cell tumors, we do a minimal staging laparotomy in which we do a omentectomy. And if there are gross peritoneal deposits, we remove those peritoneal deposits. And if any lymph node is palpable, we should try to remove those lymph nodes. Otherwise, the role of lymphadenectomy per se is not much in cases of these tumors because the metastasis is rare, and moreover, as you've already highlighted, it is a very chemosensitive tumor, so it will be covered by the chemotherapy which we give. And one more thing, the dictum for these germ cell tumor is that avoid minimum damage, because as if we compare it to the epithelial ovarian tumors at this age group, we need to start the chemotherapy fast in these. Usually the period is 3 to 5 weeks when we talk about epithelial, but in this, usually the chemotherapy should be started, as early as in the 2nd week, because they are fast growing tumors, especially these teratomas, if they are of higher grade.
So the unilateral salpingo oophorectomy with preservation of contralateral ovary and uterus was done. And this technique, this protocol should be followed in advanced disease also because of the sensitivity of germ cell tumors to chemotherapy. And no ovarian biopsy of the contralateral ovary is advocated. Should not be done. And nodal resection should be carried out only if there is evidence of nodal abnormality on imaging. So this is a picture of intraoperative picture of the tumor mass. It was around 15 into 10 centimeters mass with the prominent vessels, and the staging laparotomy was done. Histopathology was suggestive of immature teratoma, high grade. Now what is the role of adjuvant chemotherapy in this case? Immature teratoma, stage 1A, high grade.
Yeah, Dr. Taru, I would say it is a very rare case that you have, managed very well and, come across, because, teratoma that to high grade are even rarer. So especially, the grading of these teratomas is not as simple as done for epithelial and other tumors. In this, basically, we see the neuroepithelial component, and the higher the neuroepithelial component, the worse is the grading. And the higher the grade, the prognosis almost becomes half. From 80% to grade 1, it becomes almost 30% to grade 3. They behave very aggressively in these cases. So the role of adjuvant therapy lies in any of the teratomas which are beyond stage 1A and grade 1. So all the other tumors need adjuvant chemotherapy, and basically fertility sparing surgery followed by adjuvant chemotherapy, where we opt for BEP for 3 to 4 cycles. Basically, what initially we should try for 3 cycles. In case the response is low, another cycle can be added, because we don't want to give a high dose and affect the germ cells, as cisplatin falls in the medium risk of damaging the germ cells. So 3 cycles should be given, and it should be started. It is very important to start them as early as possible. Literature says as early as 7 to 10 weeks after the surgery, the chemotherapy should be started, and 3 to 4 courses should be done, and after that they should be kept in a close follow-up. And in case there is a recurrence, even after chemotherapy, then a second look laparotomy can be done for lesions which are almost more than 5 centimeters. And these lesions are mostly, these are not necrotic lesions, these are the active lesions. And usually with teratomas of high grade, there is a term used as the growing teratoma syndrome. Even if it goes away after the chemotherapy, later in the life it might return back, so they have to be in a close surveillance, these patients. And so serial alpha fetoproteins and I think CT whole abdomen should be done regularly for these patients. And just one thing for, you shouldn't be afraid in giving the chemotherapeutic drugs, because, the ovarian dysfunction is just temporary, and almost 90% of them have been seen to achieve menstruation after this. And in various studies, which are, not a very large number of studies, they have even seen that they have conceived successfully.
Yes, very true. So among all germ cell tumors, it is the immature teratoma and yolk sac tumors which are said to be more aggressive. So now coming on to how would you advise the follow-up for this patient post-treatment after chemotherapy?
Yeah. So as we all know that, they should follow up regularly. So we have done that first year, it should be a monthly follow-up, and in which we do a pelvic ultrasound, tumor markers, specifically alpha fetoprotein. The ones which are actually seen, the ones which are high should be repeated. Chest X-ray 2 monthly. And CT abdomen can be done 1 month and 3 months and at the end of the year.
So the patient,
then-
they need follow-up till 10 years, at least 10 years.
Yeah,
germ
10
cells.
years, because as I've said, there is a growing teratoma syndrome. They reoccur later in the life also. So that is how we follow most of the tumors. Yeah.
Okay,
Thank
Dr.
you.
Harika, thank you. Now, coming on to the next case, Dr. Sanjana.
Hello, ma'am. The next case is for Dr. Yashika, ma'am.
Yeah.
Hello, ma'am.
Yeah.
Ma'am, there is a young girl, 14 years old. She has reported to gynae casualty with excessive bleeding, which during her periods, which were for 6 months. She was soaking her clothes, and there was history of passage of clots. She was having some difficulty in breathing and easy fatigability and weakness. Menstrual history, Minaki was attained at 12 years of age. Her previous cycles were 5 to 6 days, 45 to 60 days coming, soaking only 2 to 3 pads with no clot or dysmenorrhea. But her now present cycles from past 6 months have been 7 to 8 days, coming frequently at 20 to 25 days, soaking 4 to 5 days pads with clots. There was no associated history of hirsutism or acne, heat or cold intolerance, visual disturbances, headache, galacturia, no weight gain or loss, night sweats, fever, cough, no easy bruisability, nasal bleeds or gum bleeding. No history of any thyroid or hypertension. Her mother and her elder sister, they had normal menstrual cycles. She's class 10 student belonging to low socioeconomic strata, sexually inactive. She took some medication for her bleeding, which stopped her bleeding initially for 4 months, but now it has started again. And there is history of blood transfusion also 4 months back. On examination, our patient was thin-built and vitals were stable. Clinically, she was 9 grams. And on per abdomen, soft, no organomegaly. Local examination was normal for our patient. We investigated. Her urine pregnancy test was negative. Her hemoglobin was low, 8.9, microcytic hyperchromic anemia. Rest investigations, including coagulation profile, were done, which were normal. This was the transabdominal scan done, which was also normal with just having a thick ET. So what is the probable diagnosis for this case, ma'am?
Thank you, doctor. So in this case, as we know, this is a confirmed diagnosis of a puberty menorrhagia with moderate anemia with anovulatory cycles. So this patient, as we know, this is the most common cause which happens in this age group because of the immaturity of HPO axis and inadequate positive feedback and sustained high levels of estrogen. So,
yes, ma'am, very rightly said. This is the puberty menorrhagia. 80% of the this kind of a bleeding is puberty menorrhagia and caused by anovulatory cycles. As very clearly said, in this age group, immature HPO axis is the most common cause behind it, as rightly highlighted by ma'am. So irregular menstrual cycle, this has been very nicely has been told by ma'am in PCOS, how we define them for young adolescent girls. Anything which is more bleeding and more than 8 days with or coming at shortest to longest 10 days with a heavy flow or frequent cycles. This is a pictorial blood loss assessment that can be done to see the assessment of severity, mild, moderate, or severe. Okay, and so ma'am, what is the role of ultrasound you will suggest in these young adolescent girls with such? We did ultrasound for this, ma'am.
So first of all, as we proceed, first we have to investigate these patients.
Yes,
because there are many other reasons which endocrine causes can be there, the bleeding disorders can be there. Obviously, pregnancy has to be ruled out. And
yes,
according to FIGO, the palm core and everything has to be ruled out. So a basic ultrasound is required. Obviously, we know it is puberty menorrhagia, but in patients like this, any fibroid, any other causes are to be ruled out. So we should not, even at age of 17, we have seen endometriomas also. So these causes should always be ruled out once after doing the ultrasound. So that is, I think it should be done.
Yes. So same as this, ma'am, in this. So now, ma'am, how to go further for managing this case, ma'am?
So with the management, actually, we start first of all with investigating and ruling out the causes which are not there. So we investigate the patient for the idiopathic thrombocytopenia, and the ACOG says that we should always go for von Willebrand factor panel also should be done. though as commonly in practice we are not seeing that. Then hypothyroidism, genital tuberculosis, PCO, leukemias, coagulation disorders should be ruled out. So after ruling out, in this patient, we have two types of treatment management. Like, first of all, what we have to do immediately and what we have to do for maintenance. The other thing is we have to calculate whether the patient, like NICE says, there are 3 types of category: mild, moderate, and severe. So which category the patient falls. If the patient, like in this patient, she doesn't fall in one set category. As it seems, according to her complaints, she had a severe episode earlier, but now she is coming into a moderate category. Because because now she is non-compliant and maybe she has not taken her medicines properly. So for this patient particularly, oral contraceptives will be a better option for her for some time, at least 6 months to 1 year. We can follow the patient for 3 months and see. Immediately, if the patient is coming with severe bleeding, we can obviously give her tranexamic acid. We can give her, in this patient, IV iron is a very good option after ruling out thalassemia. So we can give that IV iron and we can put her on iron tablets and send her home. We can treat her on OPD basis and we can give her NSAIDs also if required. And OC pills, we can, if the patient is not willing. What happens? What I see, many mothers which have come with along with the daughters are not willing for oral contraceptive pills. So in those cases, only progesterones can also be a choice for such patients, starting with a higher dose initially when the patient is bleeding and decreasing it down, tapering it down. So we can go for all the 3 options. Except in severe anemia, we should make the patient get admitted and transfuse blood.
Very rightly highlighted by ma'am and very nicely described that we have to first reassure and counsel all our patients, and then according to the severity, as ma'am said, mild can be given simple NSAIDs, non-hormonal and antifibrinolytics. In moderate, we can put them on hormones, which can be either combined estrogen and progesterone. And also, as ma'am said, mothers are not very willing to accept this. They are little have stigma attached to these pills. But an acute phase, we can use them as 1 pill every 8 hourly until the bleeding stops, and then we can continue till outpatient review with their patient doctors. And in prophylactic, we can give 1 pill daily and can see how they have a withdrawal next time. But caution, whenever we are using estrogens, we have to see any history of migraines or thrombotic risk in their family. Then our choice should be only progesterones. Then, as ma'am said, progestins, which can be initially started at high dose, given 3 times a day for 10 days, and then we can taper them off. Suddenly tapering should not be done, as can cause excessive bleeding again. And for maintenance, either they can be, rightly said by ma'am, that we can either continue on these 2 drugs in progestins. So ma'am, what are the indications of examination under anesthesia in such patients, ma'am?
Then in patients where there is failure of management, till now, I have not had such a patient, but 1 or 2 of my colleagues have gone on such under such patients. So they have so examination under anesthesia can be done in such patients, and DNC can be done for such patients, but it is rare. And if we have a sexually active patient, I think we should not hesitate in that case. Then we can go for that decision early also.
Yes.
And obviously, levonorgestrel application. Though I think I have not applied it to an unmarried or a young girl till now, but if it is the last resort, we might.
Yes, ma'am. As per our WHO also, we do not have it for nulliparas and unmarried, but yes, it can be taken as a last resort whenever the patient doesn't respond to medical therapy or severe heavy bleeding, which warrants a further investigation. Then we might have to do examination and anesthesia, and in their rare circumstances, we can offer them LNG-IUS also.
But we have done a case with a hysteroscopy without the hymenal rupture, and vaginoscopy we did, and then we did a hysteroscopy.
Very nice, ma'am.
We can proceed in such a way, and we can prevent the hymenal tear.
That's nice, ma'am. This is just the summary of this, what ma'am has, we have just discussed here and this, that if there's not bleeding heavily, we can just manage them outpatient. And if the patient doesn't improve in next 24 hours on outpatient, we can just take them IPD. And then looking at the estrogen contraindications, the high dose can be started. Not willing, just go for progestin therapy. And the most important thing is they need to be followed up in the OPD, because they are very young girls and very fragile, and then proper hemoglobin and proper counseling can help us. Thank you, ma'am. Thank you, Yashika.
Yeah. Thank you
for sharing your experience also, ma'am. Thank you. So the next case is for Dr. Rachna, ma'am. Hello, ma'am.
Yeah, good evening. Thanks for inviting me to this wonderful seminar, especially Dr. Taru. Special thanks to you and the team.
You're welcome. It's a pleasure to have you with us, Dr. Rachna.
Thank you so much.
So ma'am, to begin with, 19 years old girl coming to our gynae OPD, she had been having pain lower abdomen for 9 months. It was gradually increasing in her intensity. She used to have this pain 3 to 4 days prior to her periods, and it used to decrease with menstrual flow. And it was restricting her daily activities also, but not associated with any bowel or bladder habits. She attained her menarche at the age of 14 years, and which periods were quite regular, 20 to 22 days, 2 to 3, but she had severe dysmenorrhea. She was sexually inactive, and there was no such family history in her mother. She's a student of 12th class and doing good. On examination, she was average built, vitals all stable, and there was no organomegaly, soft abdomen, but rectal examination was significant. We could feel 5 into 5 centimeters cystic mass was felt in the pouch of Douglas, and there was thickening of uterosacrals along with this. We did an ultrasound for this, where we had 8 into 5 centimeters left adnexal homogeneous low intensity mass visible posterior to the uterus. There was 3 millimeter thick capsule of this mass. Uterus was normal, ET was fine, and right ovary was also normal. We investigated her. CA125 was raised, 340, and AMH was normal. Rest all hormonal profile was within normal limits, ma'am. So what is the probable diagnosis for this case, ma'am?
I'd like to say she has a typical history of dysmenorrhea, pelvic pain, and typical finding of a cystic mass, that too in POD with thickened uterosacrals. So based on history itself, my suspected diagnosis will go towards endometriosis, with this palpable mass being of endometrioma. Then we rightly did the first scan to see the typical finding of endometrioma, and we could see low level homogeneous echos with a wall which was uniformly thick and with no areas of solid areas. So this is suggestive of endometrioma, typical findings based on radiography. But still we should be cautious, because this is true in 90% of cases. In 10%, it can be, though it is a typical ground glass, but in my experience, we have sometimes confused it, and it turned out to be dermoid in some cases, where it was just homogeneous fluid, and sometimes dermoid do get infected and they may have pain. But she has a typical history, 9 months history, and the mass is posterior and dermoid is usually anterior, but sometimes dermoids also gets bound down. So we may be 90% sure almost that she is endometriosis, and case of endometriosis having pain, and this is a typical ground glass appearance. And we may, being she's a girl and we have to plan her management, to be 100% sure, I think we can subject her to MRI, which is not having so much exposure. And MRI, the 25% differentials which are not ruled out on ultrasound can be lowered down to 5% doubt if we do a MRI. Though MRI is also not 100%, but yes, the typical finding of T1 showing hyperintensity and the T2 showing hypointense image, and no, the fat suppression is loss of fat suppression, so it rules out dermoid. And the case is almost a diagnosed case of endometrioma with symptomatic endometrioma. So she's a 19-year-old with left endometrioma, and maybe with other, as uterosacrals are also thickened, so she may be having pelvic endometriosis as well.
Yes, ma'am. The patient had pelvic endometrioma, and by locations also, as we know theory, the ovaries and anterior posterior pouch with broad ligament uterosacral are the most common location where we can find these endometriomas. So ma'am, in what will be the best management for this girl, ma'am?
She's just 19-year-old, but she's symptomatic. So what guidelines and literature says, she has a 5 centimeter mass, which is around 7 on ultrasound. There are two options available. Either we can, for symptomatic, they say we can go ahead and do laparoscopic cystectomy, or they now recent literature from starting from 2019 onwards, they have also given reports of medical management, especially with coming of gynecologist. And from 2019, around 6 to 7 case reports I've seen that there is around 70% regression. The regression is slow. It is initially 40% in 6 months and then around 70% by 1 year. What I feel that even after doing laparoscopic cystectomy, she has a 25% chance of recurrence. She has a life ahead, and endometriosis is such a disease which will recur. And she's just 19 years old. 25% are known to recur. So then the next point to ponder for before planning her management is, if we do cystectomy at this very set, maybe she'll become symptom-free just now, but the process of endometriosis will not stop. So if we do laparoscopic cystectomy, then we have to plan a suppression even after a cystectomy, like in the form of either just GnRH or GnRH with OCP or OCP alone. That depends on our experience and our preference. There are various options available. Each has their own benefits and disadvantages. So it depends, actually varies person to person. And if the patient is persistent of immediate pain relief, then laparoscopic cystectomy is the answer. Plus we can deal, laparoscopy has advantage, we can deal with other endometriotic spots and do, but then there are various disadvantages later on in the form of loss of ovarian reserve. This is a very important point we should all ponder before opting for cystectomy. Every cystectomy, it lowers the AMH level. This has been clearly shown in various studies. And though AMH doesn't interfere later on with, has not seen in various studies कि उससे fertility कम होता है, but it does leads to decrease in AMH. Though studies have shown कि antral follicle count remains same. If you do a proper cystectomy, taking all the precautions, which I think you'll be discussing, what all precautions to be taken while doing laparoscopic cystectomy for endometrioma. In spite of that, AMH is definitely known to decrease, and hers AMH is already on the lower side, 3.4. So we should balance and discuss with the patient and take a balanced decision.
Yes, ma'am, very rightly said that medical management should be our first line in such young girls, and gynecologist has changed a lot because gynecologist can be given, and most of the patient, as ma'am rightly said, has caused regression in endometriomas and can even preserve their fertility for future. And if the patient is symptomatic or insisting, or we don't have any other option, then definitely surgery is the option, in which if there is such big endometrioma, cystectomy is the answer. And all the other adhesions and lysis, we can take the advantage and coagulate even the visible endometriotic lesions. Very rightly said, ma'am. And obviously, this all has to be in consent with the patient, her parents, and we will be helpful. And surgery has to be followed by hormone treatment to suppress the coming back, which is very, and first surgery for endometriosis is said to be the best surgery in for these young girls also, ma'am. Thank you so much, ma'am.
And I like to see in laparoscopic surgery, when we do for endometrioma, we should minimally use the coagulative agents.
Yes, yes.
Instead, now we have various other agents which can be used, like oxidized cellulose, which is used, or we take a suture.
Yes.
That is preferred over ablating, especially in a young girl.
Yes. And staying away from the hilum too, ma'am, because that's a main hub where we keep our.
Yeah, and stripping method should be followed instead of excising the fistula. So stripping and use of oxidized cellulose or suturing, minimal use of cautery and ablative procedures.
Very well highlighted, Rachna. But I just want to add that all the adolescents, they should be counseled that this is a progressive disease. So come what may, it will increase. The growth may be slow or fast. So surgery is best avoided, as you have very well highlighted. First attempt should be the best attempt.
Yes.
Very well highlighted.
An early marriage should be counseled for the parents, but they repent.
Nowadays, girls are not going because of their career options. Huh? So that is it.
Thank you, Rachna ma'am. Thank you, Anita ma'am. Thank you.
Hello, Dr. Chetna ma'am. Welcome.
Hello.
Ma'am, a young girl, 16-year-old, reported to gynae casualty with history of sexual assault 12 hours back, accompanied by mother. By an unknown person, it was a forceful act. There was no penetration present, no history of drug intoxication, and last menstrual period was 2 days back. How will we counsel the patient and take consent, and how will we do the sampling of this such patient, ma'am?
Yeah, Divya, at the outset, I'd like to thank the organizers for giving me this opportunity on talking on such an important topic and quite close to my heart. And it is actually addressing child sexual abuse is a challenge. And more so is in the setting that you have mentioned, and counseling and taking consent even are more challenging in such a case. So the main thing is to first build a rapport with the victim, with the survivor. You have to build a rapport with the survivor, and once that rapport is established, you have to develop that. You have to explain the child or the girl that it will be maintained, the privacy will be maintained, the parents problems and the apprehensions are also to be put to rest, and then only you can proceed with the counseling or the taking the consent. Now coming to the once the counseling is done, and we all know now that the one-stop centers have been established for the taking care of the survivors, and the environment should be in this case we are dealing with a 16-year-old girl, but if the child is younger than that, then the environment has also to be taken care of. It should be a child-friendly environment. While taking these consents and the case histories and examination, privacy has to be maintained. The area should be away from noises, any disturbances should be avoided. While taking the consent and the counseling part, we should avoid the presence of a third party. The police is not to be present. You may ask the child or the girl whom she wants to be present at the time of the consent taking. Now the coming to the consent, it is a step thing. It has first is the information that you have to give to the child or the girl, then the whether she's understanding the comprehension of what consent she will be giving to you, and then is the willingness of the child for the consent. Now the consent has three components. One is the history taking, so that she has to provide you with the history. Second is that she should be willing for the examination. Third is that she should be willing for the treatment that you are going to offer. And fourthly, she should understand the collection of the sexual, for the evidence of the forensic evidence that is to be collected. So all that needs to be explained in the consent, and then appropriate consent is to be taken. The consent can be given by the child in this case, who's a 16-year-old girl. For a younger child less than 12, the parent needs to give the consent, right? And the consent needs to be signed by the witness, one, the doctor, and a non-interfering party, maybe a third person or the nursing staff that you can take into consideration for signing the consent, and the parent. So that is about the consent and the counseling. Now coming to how you're going to examine the other thing is that any consent is inclusive of a refusal. You have to be very clear that it is inclusive of the refusal. So if the child or the parent refuses for any further examination or any further collection of forensic evidence, one cannot force them. But in this case, where the child is 16 years of age and comes under the ambit of the FOGSI Act, it is a mandatorily reporting to the police that has to be done within 24 hours of the girl having approached to you. So that is one is mandatory reporting. This also you have to explain to the parent and the child that even if they do not participate or give consent in the collection of forensic evidence and the other consents, you will have to report the case. And the counseling should be such that they become willing for the evidence collection. You have to tell them the importance of the collection of evidence, which will lead to conviction of the accused. So all that is important. Now coming to the examination, now it is a comprehensive care that you have to provide to the child. You have to examine her without delay, and the report has to be prepared. the name of the child, the age of the child. You can also see the documents, the school documents or the Aadhaar card. Nowadays, everybody carries one, so age estimation is not much of an issue nowadays. Then you have to, when the child reported to you, what was the time of commencement, the address of the child, the name of the parent, the accused, the history about the accused, who was the accused, if it is not known to them, the exact history of the event that has taken place. The detailed history of the event is to be taken, where the act occurred, was it one person involved or more than one person? And now in this case that you have mentioned, it is a sexual assault. That means it's a non-penetrative sexual assault. So non-penetrative sexual assault will include any handling of the private parts, any touching of the private parts. That includes the vagina, the vulva, the anus, or the breast inappropriately with intent for sexual abuse. So all this has to be, it comes under the purview of sexual assault. It may be aggravated if it has led to any injury of the child. So history of any force that has been used, any intoxication or sedation that was used during that act has also been taken into consideration. The history, then the examination of the child has to be head to toe examination, and it has to be led by the history the child has given. Now, if the child has given history of licking of the breast, then you will definitely take the sample from the DNA analysis sample from the breast area. If there has been bite marks, a thorough examination is needed. Injuries are to be reported on the body charts. The size of the injury, the color, and the type of injury has to be documented. There may have been use of physical force that needs to be documented in the history, and accordingly, the body charts have to be marked with the injury marks. Local examination of the genitalia. If there has been handling of the genitalia or any forceful act, even not penetration, even touching of that, or any forceful act that has been done without penetration may also leave injury marks and bruises or contusions, which are to be taken into account and mentioned clearly in the examination. Similarly, your sampling will be guided by the kind of history that has been given, and it will include a head to toe sampling. In case of a non-penetrative sexual assault, blindly we are not going to sample the orifices for any collection of secretions. So because that will further lead to unnecessary re-victimization of the child. So only those samples which according to history are to be taken, and care is to be taken not to secondarily victimize the child. All the samples that you have taken, like if you are taking a sample from a dry area like skin area, then that sample has to be taken with a moist swab, and then this moist swab should be using distilled water and preferably not saline. And all these samples that are taken have to be sealed, dried, sealed, packed, labeled thoroughly, and maintaining the chain of custody. You have to mention the name of the IO, your signatures, the sealing of the samples has to be done for forensic lab. Now, there are certain samples. This is the samples that have been taken for forensic evidence collection. Then other samples which include the VDRL, the samples for HIV VDRL. If the case permits, if it's a penetrative sexual assault, it's aggravated assault, then you need to take the samples for that. DNA sample may be taken on the FTA card, which is now easily available for the child. So the FTA card, DNA sample can be taken. Blood analysis also for other STDs and the basic this thing. Also is important to take vaccination history. And if the child has been vaccinated recently, because that will help you in determining whether what kind of prophylaxis the child needs. Now you have to address not only the examination and the history taking, but also you have to treat the patient. Now the treatment involves, yeah. So the question is, yeah.
And that was my next question, ma'am. How would you treat the patient?
Yeah, actually it is a comprehensive ongoing process. So I start with the treatment, history, then examination, then correction of forensic evidence, and definitely treating. Now treatment has to be for the injuries. In this case, I don't think a treatment prophylaxis for STDs would be required, depending upon what kind of assault it is. And also prophylaxis of HIV may not be required in such a case where there has been a non-penetrative sexual assault, or there has been no discharge of the semen or in any contact with the any body fluids. So specific treatment is to be given. यानी कि सबको हमको we have to give prophylaxis for STD and HIV and emergency contraceptives to all. In this case, it's a non-penetrative sexual assault, so does not require a emergency contraceptive also, and the child's LMP is also 2 days back, so it does not require a emergency contraceptive. So we treat the injuries, and yes, we give prophylaxis for tetanus if it has not been given, and hepatitis B if it has not been given.
Okay, thank you, ma'am. That was quite good, ma'am.
Actually, it's such a long topic, and to cover it.
I
in a
know,
short
ma'am.
time,
Ma'am, I was
it's
actually
of,
wanting to ask you that if there is a 14, 15-year-old girl has come and there is some history of penetration, but still they are not willing to give consent. In such circumstances, what do we do, ma'am? Usually,
yeah,
this
they
happens
have,
also with us.
yeah, it is very commonly seen, and in that case, you have to mention on your in your MLC case that they have refused for examination. We cannot now, a 14, 16-year-old child cannot be forced
Yeah,
to have. So
exactly, ma'am.
most important I will say is the counseling. This is why I spend more time on explaining the counseling and consent taking. If you tell them that it is very imperative for further treatment of the child, for further accusation and litigation or conviction of the accused, they are bound to agree. I think an expert opinion in cases of children, we generally assure that a senior consultant comes and takes counseling and does make a lot of difference.
That is
And
being followed in our hospital also,
and
ma'am.
they,
That is
then
there.
the child
Yes,
and the
ma'am.
parent does generally agree for a safe examination, especially if it has been a penetrative assault.
Okay, ma'am. Ma'am, what are
And
the
small
guidelines
follow-up.
for the use of
Yeah.
professional and experts under POXO Act
Yeah.
2012, ma'am?
I would like to highlight here that what guidelines that we have is, and I think all of us should be aware of, is the apart from the POXO Act and the Sexual Offences Act 2012, the guidelines have been clearly laid down by the CWC. So if you go onto the website of CWC and you click on to the guidelines for management of or the medical legal care of child abuse, will find they are laid down, and they were published in 2013. Now this POXO Act, now it is a very comprehensive act which allows for protection of children from the offences of sexual assault, whether penetrative, non-penetrative, also harassment and pornography.
Ma'am, as you are going behind, your voice is not audible. It is getting, yes, ma'am. You have to come a little nearer to the mic.
Yeah, I'm saying that it is a comprehensive act which includes all the stages of sexual abuse, all the kinds of sexual abuse, not only sexual assault, whether it is penetrative or non-penetrative, also inclusive of sexual harassment, of pornography, and of any also abetment. Those people who have not brought forth the reporting of such a case, if they were in knowledge of that or have been a party for enhancing this act, are also brought under the ambit of this POXO Act. Now, the penetrative sexual assault is an offense in which involves penetration of penis into vagina, mouth, urethra, anus, not only penis, of any other object, even fingering. And that also, even if it has to a minor extent come near the vagina or at the level of the introitus or organ, has to be included as a penetrative sexual offense. Then this aggravated in case it has been done by any person who is in authority, is responsible for the care of the child, like in a school, the school authorities, anybody from the school authorities, policemen, or somebody who is a government employee does this, it becomes under aggravation if the child is led to certain mental disability or physical disability, or the child falls pregnant, or it results in the death of the child. All these come under the ambit of an aggravated penetrative sexual assault, and it can amount to imprisonment for life term. The sexual assault does not involve the penetration into the vagina. Such all cases done with an intent to harm the sexual with a sexual intent come under the ambit of sexual assault, and the punishment in these also has been risen by the amendments of 19 and 20 to up to 6 years. Now, the abatement I've already mentioned, and that only those responsible for leading to such an act, have been supportive in such an act and not directly conducted such an act, are also liable for 6 months of 6 months of imprisonment and fine. Now, a very important part is that if we come across a child who has been sexually abused, or anybody who has come across a child who has been sexually abused and does not report this event to the authorities within 24 hours of having come to know this, is also liable for litigation under this POXO Act. So it is mandatory to report this, and this reporting is done to the special juvenile police units or the district child protection unit, or directly to the police for this purpose.
Ma'am, as ma'am said, the reporting of cases of child sexual abuse to the law enforcement authority is mandatory for all. Failure to report a case of child abuse is an offense and can cause litigation. Reporting is obligatory even if the information is acquired as a part of professional duties with a confidential relationship.
Yeah,
Any
I would like
private-
to mention here that if a child has come to you with a history of, say, abnormal discharges or pain during defecation or pain during
Yes, ma'am.
urination, and you realize that maybe the child has undergone sexual abuse,
Yes, ma'am.
you are legal duty and you're bound to report this. Right? So that comes under the ambit of FOGSI.
Okay, ma'am. Then we are that means that it is our duty that we have to inform the
Yes.
police if we find anything
Yes.
suspicious. Also.
Otherwise, we are liable for
Yes,
litigation, and we may undergo an imprisonment for up to 6 months as well as fine.
Okay, ma'am. Ma'am, what are the POXO Amendment Act 2020?
Actually, there were two amendments since the Act came into being in 2012. There was a 2019 amendment which specified the people who specific terminology as put to care taking of children even in school, places like creches or
Your
other.
voice is, I don't know why it is stopping in between.
Okay, I'll go a little slow maybe. Am I audible
Yes,
now?
ma'am. Now you're clearly audible, ma'am.
I'm trying to say is that there are two amendments that have taken place. One has taken place in 2019 and one has taken place in 2020. The one that you have asked is the 2020. In this, the minimum punishment has been increased from 7 to 10 years of imprisonment. And if it is an aggravated sexual assault with penetration, then imprisonment has increased up to 20 years and even life imprisonment or even a death penalty. So, further, if it is done with a child less than 16 years, it can be death penalty also. So these are the two important changes that have been amended in the in 2020.
Yes, ma'am. Assault resulting in death of the child and assault is committed during a natural calamity, ma'am.
These are the two things which have been added as a definition for
As a aggravated
penetrative
sexual assault.
Aggravated sexual assault. If done in a natural calamity, or results in grievous injury or death of the child, will be inclusive under aggravated assault.
The amendment adds two more offenses to the, as we have already discussed, during a natural calamity or administering or helping in administering any hormone or any chemical substance to a child for the purpose of attaining early sexual maturity.
Yes, yes, definitely.
And these are the punishment that has been.
These are under section 3, 5, 7, 9, and the punishments are under section 4, 6, 8, 10, and 12.
So, ma'am, this I have just concluded that POXO Act 2012 looks into a support system for children through a friendly atmosphere and the criminal justice system with the existing machinery. The positive aspect is the appointment of support person for the child who would assist during investigation, pre-trial, trial, and post-trial. The major challenge also would be convergence between different entities until different legislation. And the Act makes it mandatory to report to the police about any offense defined under POXO Act 2012. Thank you, ma'am. Ma'am, this is a little deviated from the adolescent topic, but I just wanted to ask, ma'am, if a 5-year-old victim comes of sexual assault, like how do we proceed in such a patient, ma'am? Like the person is, the child is not able to get herself examined. We're not able to examine her just like that. So how do we proceed in such a patient?
Dr. Divya, the basic principles of history taking examination remain the same. If the child is very young and feels comfortable with the mother, the child can be examined in the lap of the mother or the guardian who is coming so that the child is made comfortable. Still, if you feel that the sampling is necessary or the examination is necessary and the child is uncooperative, I think you want to highlight that.
Yes, ma'am.
If the child is uncooperative. If the child is uncooperative, there are very specific indications where you can give sedation to the child. If you feel that the child needs treatment or sampling is required and the parent has given a consent for the same and the child remains uncooperative, sedation can be tried. Now we have the help of our pediatricians here whom we do call in cases of a very young child, and the drugs that are generally used for sedation are midazolam, fentanyl. These can be given in a dose modified manner for the child. And as soon as the sedation achieved, you can proceed with the examination. Generally, the effect of these drugs lasts for around 3 to 4 to 6 hours, and a complete examination can be performed. Now comes in case you are suspecting an injury, or you need to do an internal examination or speculum examination in a prepubertal or such a young child, then yes, we would need a general anesthesia. If there is an injury in the vagina or in the genital area which needs surgical intervention, or the sampling needs to be done with the use of an instrument, then definitely we have to go in for a general anesthesia. Otherwise, most of the cases that we have seen is are responding to either counseling or the mothers, taking the child in the lap, or if required, we have resorted to sedation, oral sedation.
Sometimes the child may not agree.
Very true, very true. At times, and
in
then we
that
have.
case, yes, you can counsel, you can call her the next day, but you document that she had reported on so and so date, she was counseled, and you must tell the parents that it may cause, loss of some
evidence.
Yes. But still, if
But
the
if
child
we
has
have been told that we have to inform within 24 hours, then that in that case,
No,
if we send
police has to be informed.
I would like to answer that. Dr. Anita is absolutely right in saying that you may defer the examination part. Your reporting has to be within 24 hours. Your reporting has to be within 24 hours. But on that, your sheet itself, you have to document that you have asked the child to come in a few hours. At times, the mother may all that has to be done with a lot of sense of protection and privacy, and not forcing any examination. It can be done, no doubt about it. If they want to come the next day, you can call them the next day.
And another very good thing Chetna has highlighted is if you have telltale marks, like you have STIs in 12-year-old or 11-year-old, they may be an indirect sign of child sexual abuse. So you should have a very high index of suspicion in these
doctor
cases.
has a
Because the
dual,
child,
doctor has a dual role. One is in
Yes,
identifying the cases of child abuse is also very important for us, being gynecologists.
Divya, there is one term called child grooming. The child may be persistently abused, but she may or he may not know that he is being abused because he has been groomed like this. So we should have a very strong sense of,
Ma'am, it is a very important topic. We actually can create a proper CME for just discussing all this only. But actually, it is a very, very important topic. So I just
but very well covered by Dr. Chetna.
Yes, ma'am.
I tried to concise it into whatever I could have. There are few
Chetna, ma'am,
yes,
ma'am. Ma'am, you have explained very nicely, ma'am. Very nicely. Thank you so much. In such a short span of time, you have covered everything almost.
Any other queries? What I have faced, another problem which I would like to discuss in this forum is that there are times when the parent refuses to give a consent for an examination, whilst you feel that the parent itself is involved. Yeah, the parent, it may be a case of incest in which the parent is not coming forth for examination. So we have, actually put up a request for revision of the medical legal care systems where, this is also addressed. Hopefully, the government of India is revising these guidelines and this will also be dealt with. As of now, what we are doing is we are taking into consideration 2 medical officers or 2 specialists who give consent, and the evidence is preserved and may be produced at a later date if required.
Yeah, Dr. If I can please come in. If you remember, we've been we have been in trouble with such cases when the parent itself was involved. So and just one more thing I said, in cases of difficult or deeper injuries, involvement of pediatric surgeon is also of utmost importance. So you can get a good help from them also whenever there's a very deep injury or the rectum is involved. So.
And another important thing is referring the child to child psychologist, because they have
actually I've not been able to cover all the aspects because of the specific questions.
Yeah.
Yes, ma'am. Ma'am, I was actually discussing with Dr. Chetna before also. Ma'am, I told you, like in our setups in India, we don't have any child psychologist in our hospital. But actually, proper interviewing should be done in the presence of child psychologist, and it would be easier for us to take the history and even examine also.
Dr. Divya, the interview part is also done by the legal authorities where they definitely involve. Once you have reported the case, then the police itself has to inform the CWC within 24 hours so that appropriate interviewing can be done, and that is being done for all cases. जब आपके पास से report हो जाता है, then the patient, the child is definitely given a support person for
child
counseling
psychologists are
and
not.
retaking of the history, though they don't want re-victimization, but if we are deficit, it is being done in all cases.
Ma'am, yes, ma'am, it is being done by the police also, but I was wondering, like, child psychologists would play a better role. That's
Bilkul,
all,
and
ma'am.
you, yes, you have to give a referral. You have to give a referral. After 2 weeks and 6 months for seeing whether the child has developed any residual post-traumatic stress or not. It's a part of our duty, and we should do that.
Thank
And we must stop addressing the concerned person as a victim.
Survivor, yeah, survivor.
Survivor, actually.
Survivor. Use this word survivor.
Survivor. Oh, thank you, Dr. Chetna, ma'am. Now, next, I'll proceed to Dr. Anita, ma'am. For you, an 18-year-old sexually active unmarried girl has reported to your OPD. She is scared that she might get pregnant. Her last menstrual period was 5 days back, and she's having regular periods. How do you counsel the girl, and what would be the contraceptive advice for her, ma'am?
So thank you for that question. She is 18 years. You have very smartly put her age as 18 because you have already covered the FOGSI. Of course, she can give consent for sex now. We have to inquire whether it was the first encounter or she has had previous encounters. And you have to take a detailed history, as Chandan Kachru ma'am had already highlighted. You have to, heads, you have to take into account how many means you have to take her into, faith and confidence, and then inquire how many sexual partners she has, and if the partners have multiple sexual partners, what contraception she usually uses, because she has had just last menstrual period was just 5 days back. We need not get worried about her pregnancy. She has to be, counseled in a very comfortable way that the chances of getting pregnant are very, very remote. If the cycles have been regular, she has been menstruating regularly, and the menstrual flow was normal this time also. And regarding further counseling, you have to counsel them regarding, we can't be preachy to these adolescents, and we can't be judgmental. That is for sure. We will, sit with them, listen to them, and then advise them that there are chances of contacting sexually transmitted infection also. So she needs to be screened for those infections. And then accordingly, we will counsel her for contraception also. And usually adolescents are given advice of dual contraception, because condom, they will prevent them from STIs and other things like you can use even intrauterine. There is no contraindication for any type of contraception. All contraceptions can be provided. The whole basket has to be offered. Whatever she chooses can be given to her. Even they say even COCs can be given. She can be offered DIMPA also. Initially there was some concern whether there will be bone loss, but it has not been documented. So she can be given POPs also, depending on her medical condition. If there is any, you will. So all contraceptions will either fall in MEC category 1 or 2, and they can be safely given. And in foreign countries, they say even smaller, intrauterine devices are also available for adolescents. So we can offer them. But suppose this patient had come in mid-cycle, and then we had to counsel her to give emergency contraception also, because we will ensure that she's not pregnant at that particular time. And she has to be counseled very, very, in detail, that emergency contraception should not be used as a regular contraception if she is continuing to be sexually active. So these are the points of counseling which have to be reiterated again and again to these adolescents.
Ma'am, actually in India, even though the age has increased, in the educated population, that age has increased. Like otherwise, in rural areas, still our ladies are getting married at the age of 17, 18, 19. So the contraception knowledge is very scarce in them, ma'am. They don't have that knowledge. So it was like, it should be,
Awareness is one
awareness
thing,
has to be increased.
and then availability.
Availability
Even if
also.
they have, if they are aware, because they may be aware through internet, then they will be, feeling ashamed to go to a gynec or a physician to ask for
Even
contraception.
coming, yes, ma'am. Even coming to the hospital, like, ma'am, we conducted a program, a ESI Pakhwada, a few days back, and we had kept a condom box. So in that, many condoms were kept. So they quietly came and took. They were taking out the condoms quietly. Otherwise, they become so hesitant that they should come to us and ask for condoms. But I saw the whole box was finished, ma'am. By the end of the day, but it is like, for them, it is difficult to ask. But when it was kept, they were taking it out and they were using. Yeah.
It should be kept on help desk,
Yes, ma'am.
You put them in the morning, and after 2 hours, the box will be empty.
Yes,
and my sister was surprised by seeing this, because initially all the people were coming to the sister in charge in family planning OPD. Hardly any males were coming.
Yes, ma'am.
So I said that you change this practice, keep it on the help desk.
Help desk.
And after 2 hours of keeping that, nursing orderly came, ma'am, the box is empty.
The box is finished. Yes,
Have the same experience daily, because they feel, actually they feel embarrassed in coming to a gynecologist and asking for contraception.
Yes, ma'am.
And we should have regular adolescent health clinics also.
Yes, ma'am.
It should be on a comfortable day. If your locality has, chutti on Saturday, you keep adolescent clinic on Saturday, so that they can readily come and attend those adolescent health clinics. And it is a good opportunity for screening for other health issues also. Like, you can screen for anemia, you can screen for so many other things. It can be a good opportunity to consider their other health conditions also. So you have to take other things also into consideration. Are there any comorbidities also? So that has to be kept into consideration. And prevention of STIs and treatment of the same has been already highlighted by me.
Ma'am, my next question is, there's a 15-year-old girl who has come to you in OPD. She had her last menstrual period 6 days back, and her cycles are regular. She has itching in perineum region whenever she gets her periods. Ma'am, I just wanted to ask, like, what do we understand by menstrual hygiene, and how do we counsel the girl regarding the same, ma'am?
So again, in continuation with the previous, we have to again take a detailed history. Head's history is to be taken, whether she is sexually active or not. And we have to counsel the girl, and her mother also sometimes has to be called in, and they have to be explained about proper menstrual hygiene. So menstrual hygiene is not just using the products for menstruation. It is a whole culture which has to be told to them, that they have to keep their personal hygiene proper. You have to counsel that sometimes they will not take bath. So you have to counsel their mothers that there is no harm. Rather, they should wash their perineum properly. Wash facilities should be available. Wash facilities are water, sanitation, and hygiene. They should have privacy. They should have toilets even in school, so that they can clean themselves properly. All the menstruators, by menstruators I mean adolescent girls and transgenders also, or whoever is menstruating, they should be given this counseling. They should have facility for absorbent also. There are various products available which we can highlight at present. They are, pads are there. There are, cloth pads are reusable cloth pads are available. Then menstrual cups are available. We have tampons also. Recently, in South India, they are making pads with bamboo fibers and banana fibers also. So they are using that. Sometimes even wool. Of course, in India, it will not be possible to use that because of the humidity and heat. But they are known that some of the countries are using them also. So various products have been used as absorbent. But there is a word of caution that super absorbent material was withdrawn from market, because they used to just forget it. They were super absorbent, they will keep on swelling, the girl will keep it for 6 hours, 8 hours, and then 1 or 2 mishaps were there. There was toxic shock syndrome, so super absorbent material was withdrawn. But we can use other products also, as they have already shown in the picture. So menstrual hygiene is not only used, but every aspect of it has to be dealt. And one more important thing is how to dispose of. They have to properly dispose of the used material. If they have used it, a disposable pad, how to pack it, how to throw, which dustbin to use, where to throw them. They should not throw it here and there, and because it can cause hazard to other people also. So they have to be counseled, their mothers have to be counseled, their teachers, and there comes the role of brothers and fathers also, because the girl should not feel ashamed of telling that she is having menstrual, because menstrual management involves the family also matters a lot. So all the boys, all adolescent brothers and fathers, they must be counseled that this is not something to be ashamed of. They should share some responsibility, because it is a natural process. So everybody needs to contribute towards the menstrual health of that girl in the family.
Yes, ma'am. Ma'am, very well covered, ma'am. You've almost covered everything. Thank you so much for such a wonderful talk on this, ma'am.
So I would like to thank all our panelists, ma'ams, for such participation and giving us such an evidence-based discussion for all. And it was a very informative session that we had here. Thank you, ma'am, for all this valuable time. Thank you, all the ma'ams, from all the moderators. Thank you, ma'am.
Thank you. Thank you on behalf of AOGD Adolescent Health Committee. It was a great academic feast. All the speakers, panelists, moderators have been great. Thank you everyone. And thank you, Shivam, for providing the IT platform.
I would like to thank AOGD President, ma'am, Dr. Asmita Rathore, and AOGD Secretary, ma'am, Dr. Deepti Goswami, for providing us this esteemed platform of AOGD. I am really grateful to our MS, ma'am, Dr. Govil, and our Dean, Sir Dr. Pascal, for providing us this opportunity. And all the esteemed chairperson, it is my honor to thank dear Dr. Sangeeta, ma'am, Dr. Deepti, ma'am, Dr. Shashilata Kabram, and our dear Dr. Anita Rajoria, ma'am. You have been given our constant inputs, very thankful. And I'm thankful to Dr. Chetna Sethi ma'am, Dr. Niharika Dhiman ma'am, Dr. Nupur ma'am, and Dr. Rachna ma'am, and all our esteemed speakers also. Thank you, Dr. Taru Gupta ma'am, our esteemed pillar, and our HOD, who's been a pillar of our Obs and Gynae department, and all my senior colleagues also. It was a pleasure to be part of this academic feast. It is always a pleasure to meet all our respective seniors on this platform. And thank you, Shivam, for all the technical help. You have been a very good person. Thank you so much, ma'am. And I'll just put to Dr. Taru. Yeah.
Yes, I would like to thank Dr. Anita, Dr. Smita Rathore, Madam, Dr. Shashilata Kabra. It was just because of all of your efforts we have been able to conduct a successful webinar on adolescent. It was a long awaited. Dr. Anita was pursuing since long time.
We are very grateful
we
to you
have
for
do
that,
this
ma'am. Thank you so
this
much,
topic.
Anita, ma'am.
So thank you so much. Thank you so much.
And thank you to all the participants who have sat through the webinar.
Yes, ma'am.
Without them, it won't have been a success.
More than now 2 hours. Thank you.
Yes,
Thank you,
more
everyone.
than 2 hours. Yes, ma'am. Thank you.
so
Bye,
much.
ma'am.
Thank you, Dr.
Thank you.
Rachna,
Bye-bye.
Thank you, Dr. Taru.
Thank you.
Sam.
Okay.
Thank you,
Bye,
everyone.
ma'am.
Bye-bye.
Thank you.
Bye, everyone.
Bye.
Bye-bye.
Thank you, ma'am. Bye.
Bye-bye.